Very good morning to all of you. On behalf of our organizing committee, I welcome all delegates, honorable speakers, and chairperson in Day 2 scientific session of Jaipur Heart Rhythm Summit. Thank you very much. Now I would like to hand over scientific session to honorable chairperson.
Hello, good morning everybody. Since we are already late, we have a quick start with the second day of the Jaipur Heart Rhythm Society. May I request Dr. speak on newer drugs for heart failure. Dr. Sanjeev.
Yeah, thank you, Chairperson, and good morning, everyone. And I welcome you all on this 2021 Jaipur Heart Summit and Heart Rhythm Summit. And I would like to thank Dr. Makkad for giving me the opportunity to deliver talk on newer drugs for treatment of heart failure. So before coming to drugs, we'll just go through few slides so that we can know that how we can divide the phenotypes of the heart failure and how we can diagnose. So definition I will not go through. So this is on the right side, you can see this is a diagnostic algorithm for diagnosis of the heart failure, and measurement of anti-pro-BNP or BNP levels. They have been given class 1 recommendation for diagnosis of heart failure. And if they are found to be elevated, then echocardiography should be performed to determine the phenotype of the heart failure. And there is some renaming of stages also. Stage A is now called at risk for heart failure, stage B is pre-heart failure, stage C heart failure, and stage D is called now advanced heart failure. And depending on the echocardiographic findings, we can divide the patient into 3 parts. The patient who has got ejection fraction of less than 40%, they are called heart failure with reduced ejection fraction, and patient who has got 41 to 49% ejection fraction, they are heart failure with the mildly reduced ejection fraction, and more than 50% is called preserved ejection fraction. And the patient who are previously in the reduced ejection fraction category, but with treatment their ejection fraction improved, they are called heart failure with improved ejection fraction. Just to give this is the inter-CHF study which showed that Indian patient, despite being younger, they had higher mortality rate as compared to other parts of the world. So we need to be very aggressive for the treatment of Indian patients. So this is the pathophysiology. We know that the activation of neurohumoral axis, and there's imbalance that leads to a vicious cycle and ventricular remodeling. So to improve the prognosis of the patient, we need to break this cycle. And this was being done with these medications which were classically being used for the treatment of heart failure, that is ACE inhibitors, beta blocker, they were the cornerstone, then MRAs and ARBs and ivabradine, and these are the conventional drugs which were being used. So do we really need new drugs? Because all these drugs seems to be quite effective. Yes, we do need new drugs because still 50% of the patient, they die within 5 years of the diagnosis. So this is the positive outcome trials of all the trials of heart failure with reduced ejection fraction. And you can see that after 2014-15, many new drugs have been come, and we will discuss all these new drugs in today's presentation. So ARNI was the first drug, and conventionally with the ACE inhibitor or ARB, we were taking care of only the renin-angiotensin system, and we were not taking care of natriuretic peptide system and bradykinin system, which have many beneficial effects in the patient with heart failure. So with the ARNI, we can take care of, we can not only block renin-angiotensin system, we also actually promote the activity of this natriuretic peptide system and bradykinin system. So this was the trial in which the drug was tested. The name is sacubitril valsartan or ARNI, and Paradigm HF was the trial. Almost 8,000 patients they were enrolled, and initially there was all the patients were already receiving doses of enalapril, that is 10 milligram BD, and then they were randomly assigned to either sacubitril valsartan or enalapril. So this is the result. You can see that primary endpoint of cardiovascular death or heart failure hospitalization, they were reduced significantly by 20%, and you can see the p-value, which is very significant. All the individual parameters like cardiovascular death, heart failure hospitalization, overall mortality, the heart failure death, and sudden death, all these parameters were also significantly reduced. So drug was found to be very effective. So now what is the mechanism of benefit? How this drug makes so much of benefit? So that was actually proven in the PROVE-HF trial, which showed that there was evidence of reverse cardiac remodeling with the use of sacubitril valsartan, and all the parameters of systolic dysfunction as well as diastolic dysfunction were improved with the use of ARNI. And you can see that there was increase in ejection fraction, and there was reduction in left ventricle end diastolic volume and left ventricle end systolic volume as well. And there was 25% of the patient, they had more than 13% increase in the ejection fraction at 12 months. There was improvement in diastolic parameter also. There was a reduction in left atrial volume index, and there was improvement in E to E prime ratio, or suggestive of improvement in diastolic parameters. So till now, the drug was used only in the patients who were already receiving AC inhibitors, but this drug was so useful, so can we use this drug in the de novo patient or hospitalized patient? So this concept was tested in the Pioneer-HF study. 888 patient who were admitted for acute decompensated heart failure. Once they were stabilized, they were randomly assigned to sacubitril valsartan or enalapril, the dose of 200 milligram twice daily, target dose of 200 milligram twice daily, or enalapril of 10 milligram twice daily. The definition of stabilization was systolic BP of more than 100 in prior 6 hours, and no symptomatic hypotension, no increase in IV diuretics in prior 6 hours, no IV vasodilators in prior 6 hours, and no IV inotropes in prior 24 hours. So these are the results. You can see there was significant more reduction seen with the use of sacubitril valsartan as compared to enalapril, and cardiovascular death and hospitalization for heart failure, they were also reduced. So from this trial, it was clear that drug was effective in all the subgroups, that is de novo who were not receiving any prior treatment, and the drug was effective in worsening chronic heart failure. Drug was effective in patients who were already on AC inhibitor, ARBs, or patients who were not receiving a prior AC inhibitor or ARBs. So transition study again confirmed that we can safely start sacubitril valsartan in hospitalized and acute decompensated failure. And this trial also found this drug was more useful, more effective in the de novo patient. So now we know that we can use the ARNI in all the patients, like clinically stable patients, acute decompensated patient, or newly diagnosed patients. So based on these findings, ACC 2021 expert consensus decision pathway recommends that ARNI as first line treatment versus AC inhibitor ARB as one of the new strategy to improve the outcome in the heart failure with reduced ejection fraction. As you can see, that number needed to treat for ARNI is 11, and number needed to treat for AC inhibitor is 18. Now coming to the second class of the drug, which is SGLT2 inhibitors. SGLT2 inhibitors, they were actually developed initially as anti-diabetic agents. And we all know that there is some filtration of glucose from the glomerulus, and this glucose is actually reabsorbed in the proximal convoluted tube through the sodium glucose co-transporter, and main absorption occur with the SGLT2, and blocker of this receptor was actually developed as an anti-diabetic agent. Now it is, we know that it is must to have outcome trials for any new anti-diabetic agent. So while outcome trial for SGLT2 were being conducted, it was observed that they not only improved the cardiovascular outcome, they also reduced the hospitalization for heart failure also. So therefore, dedicated heart failure trials were conducted. This is the mechanism of action of SGLT2 inhibitors, and they actually induce diuresis, and they increase glucose excretion and natriuresis also. So all these factors, they lead to multiple benefits in the overall system, and there's improvement in cardiac function, that is reduction in preload, afterload, and because of production of some ketone bodies, there is improvement in cardiometabolic efficiency also. There is reduction in left ventricle mass, there is reduction in blood pressure, reduction in weight, and there was improvement in kidney function was also observed. So this was the RECEED HF trial, which have shown that when SGLT2 inhibitors, they were given on the top of loop diuretics, they only increase the free water clearance and the urine volume there is increased, and there is no change in excretion of sodium. So when we compare these SGLT2 inhibitors with the other diuretics, we can say that they are not associated with any electrolyte imbalance or hyperuricemia or metabolic alkalosis or acidosis. So the first dedicated heart failure trial with SGLT2 inhibitor was the DAPA-HF trial, which was in which dapagliflozin was used, and this was the trial design. The exclusion criteria which was kept was eGFR of less than 30 patients. They were not included in this trial. And this is the result, the primary composite endpoint of cardiovascular death, heart failure hospitalization, or urgent heart failure visit that was reduced significantly in both diabetics as well as non-diabetics. The hazard ratio for diabetics were 0.75 and for non-diabetics it was 0.73. The secondary outcomes of hospital all-cause death were also reduced with the hazard ratio of 0.78 in diabetics and 0.88 in non-diabetics. The empagliflozin was tested in EMPEROR reduced study, and you can see again the primary composite endpoint of cardiovascular death or heart failure hospitalization. There was 25% relative risk reduction and 5.3% absolute risk reduction, and number needed to treat was 19. The p-value is significant, and first and recurrent heart failure hospitalization were again reduced by 30%, and there was improvement in kidney function also. So now coming to that, it is normally thought that when patients are being given ARNI, the SGLT2 inhibitors, they might not be useful. But in this trial, almost 20% of the patient they were receiving ARNI also, and drug was found to be benefit even in the patient who were being given ARNI. And because there was mortality benefit was seen very early, as you can see that the curve started separating from very early from 2-3 days, and it reached clinical significance as early as 12 days. And because of we have observed that improvement in kidney function is seen in all the SGLT2 inhibitors trial, so it was seen in this trial also. So because of there is improvement in kidney function, there are less chances that there is discontinuation of MRI therapy. So there were 22% lower risk of discontinuing MRI therapy when SGLT2 inhibitors were being used. And because of improvement in kidney function, there was improvement in erythropoiesis also. So less chances of anemia was seen in this trial. So there were some regional influences were also noted, and we can see that this drug was found to be more effective in Asian patients as compared to Europeans. So this is a summary of all the three drugs. You can see that all the three drugs, they are quite effective, and absolute risk reduction is in the range of 5.3 and number needed to treat in the range of 20. So this is the new class of drug, which is soluble guanylate cyclase stimulator. We all know that in the heart failure, due to oxidative stress and endothelial dysfunction, there is reduction in nitric oxide activity, and that leads to reduction in soluble guanylate cyclase activity. This guanylate cyclase, when activated, leads to production of cyclic GMP, and which has got very beneficial effect both in myocardium as well as in vasculature. And when this drug is given, the name of drug is the Vericiguat. When it is given in the heart failure patient, that leads to stimulation of the cyclic soluble guanylate cyclase directly as well as through the nitric oxide also, and there is increased production of cyclic GMP, which leads to reduction in progressive myocardial stiffening, reduction in myocardial thickening, reduction in ventricular remodeling, and reduction in fibrosis also. In vasculature, it was found to reduce reduction in arterial constriction as well as stiffness. So this drug was tested in the Victoria trial, almost 5,000 patients. They were already on OMT, and after a worsening event, that is either hospitalization or use of IV diuretic, and there were elevated natriuretic peptide level also, they were randomly assigned to either receive Vericiguat or placebo. And there was 10% reduction in composite primary composite outcome of cardiovascular death, hospitalized or heart failure hospitalization. So based on result of this trial, this drug has been approved by the European Society of Cardiology recently. This drug has been given class 2B recommendation for treatment of heart failure. This is the new class of drug. This is called cardiac myosin activator or myotropes. This drug is called omecamtiv mecarbil and mecarbil. And this drug basically addresses the basic pathology of the heart failure, that is reduction in the contraction of the myocardium. None of the other drug was being evaluated with this mechanism of action. And what this does is actually it activates cardiac myosin and augments the speed of ATP hydrolysis and thus accelerates the production of strong actin myosin complex and recruits more number of myosin heads, which leads to increased force production, and it leads to increase in cardiac contractility and increase in cardiac output. And because this drug does all this increase in force independent of calcium hemostasis, so there is no increase in myocardial oxygen consumption and no change in LV dP by dt. So this drug was tested in the Galactic HF trial, and there was 8% reduction in the primary composite endpoint of cardiovascular death and time to first heart failure event. And although it was overall it was not significant, but in the subgroup analysis, it was seen that patient who has got ejection fraction of less than 28%, this drug was found to be very effective. So this is the therapeutic algorithm for the treatment of heart failure with reduced ejection fraction, which has recently been given by ESC guidelines, and all the 4 drugs, that is ACE inhibitor, ARNI, beta blockers, MRA, SGLT2 inhibitors, they are given class 1 indication, and loop diuretic definitely can be used. They are also class 1 indication depending on the symptoms. And if patient remain symptomatic despite use of these drugs, or there's we are not considering device therapy, or that is not indicated, then we can add the class 2 agents in treatment options. So adding therapy is adding life. So patients who are receiving more therapy, that is 3 or 4 drugs or 5 drugs, they have got a better prognosis as compared to the patient who are receiving less number of drugs. So we should try to give all the drugs which can be given in the patient with heart failure. So there is early post-discharge mortality is very high. So it is recommended now that all the disease-modifying treatment that should be started within the acute phase, that is during the hospitalization, and the doses should be treated within the first 3 months, so that we can improve the prognosis of the heart failure. All these has been given class 1 recommendation by the latest ESC guidelines. Now, this conventional sequencing actually was associated with a lot of delay for the treatment. Therefore, some rapid sequencing has been we can actually so on screen, just one slide that we can actually make the patient profile, so that we can decide that which drugs to be used as the first line, and then other drugs which can be contraindicated, or they are they cannot be added. So these are just one last slide. Till now, there were no drugs which was found to be very effective in treatment of heart failure with the preserved ejection fraction. And because all the trials like CHARM preserved, I preserved, PEP CHF, TOPCAT, Paragon HF, and DIS-PEF, they were although there was some improvement, but it did not reach statistical significance. But now, last month, Emperor preserved trial was presented in the ESC meeting, and the empagliflozin was found to be effective in the patients with heart failure with the preserved ejection fraction also. Thank you.
Thank you, Dr. Sanjeev, for an excellent role of newer drugs in management of chronic heart failure, which is increasing rapidly across the all spectrum of and their synchronous effect is very useful with lack of their side effects. But depending upon the etiology of muscle, whether it is ischemic muscle fiber or it is a virally affected muscle fiber, the role of these drugs has very important role when to add and when not to add. Since we are short of time, the session is open for questions, 1 or 2. If no questions, thank you, Sanjay.
Thank you. I think we can have discussion at the end of the session. For the next talk, I'll invite Dr. Kush Bhagat. There's some change in the presentation for the discussing about ICD, CRTD, and CRTP. What is right for my patients? And Dr. Kush is also one of the elective jurists working at the Retina Heart Center. So let us see what he has new for this topic. Dr. Kush, one second.
Thank you so much, sir. And thank you so much, Dr. Sidana, for giving such an excellent talk. So, yeah.
So, Dr. Vanita was given this talk, but unfortunately she couldn't arrive. So what we have done is we'll take this talk as a panel discussion, and there are some case examples which Kush will present, and then what appropriate kind of therapy we can we can offer to that patient. So for that, I would also like to invite Dr. Anup Gupta and Dr. Anil Saxena on the dais, so that we can have some expert comments too. Please.
So no doubt there are many drugs for heart failure. He's a 52 years old male, diabetic, hypertensive, NYHA class 3. ECG has left bundle branch block and QRS is 130 milliseconds. Echo is suggestive of severe LV dysfunction, EAP 25% and normal angio. So in short, he's a case of DCMP, LV dysfunction, EF 25%, ECG has left bundle branch block with QRS of 130 milliseconds. Now, question is, so we have given all the gliflozin, ivabradine, ARNIs, but despite that, patient is symptomatic. He's in NYHA class 3. So what should we do? So do we have any option for these patients? So, so what is right for this patient? We should go for CRT, we should go for CRTP, D, or ICD. So I would like to have your take.
Well, okay, what you're saying is that cardiovascular is so straight comes individual CRT. Now, the question is whether you want to get only CRT patient versus equivalent. So certainly, I would like to take a starting part in this patient to see whether there is a late heterogeneous diabetes. If the cardiac MR doesn't show any process, that patient sorry I go for CRT. But who's important, we need to counsel the family. See, again, in India, how can the public medical there? So, traveling, willing to get a CRT, that there's no question coming up to the CRT. Scientifically, on your test, class 2, and the cardiac MR is low, fibrosis, low, 8, get away and for the CRT.
The benefit of ICD in non-skin cardiomyopathy is less than the first, and especially we are doing CRT despite likely that the patient that might improve beyond 5%. But and also they found that the other therapies, not only mortality, heart failure, even ICD rather than 25% per year. And so it shows competitive. Now, ICD, the same classes have to take this level to show that competitive dimension. So we are now doing more targeted therapy of ICD in non-skin cardiomyopathy. Patients who have scarred I think they are more likely to have arrhythmias. So that on one side we can do MRI to look at the scarring pattern, and if it's significant scarring, then we should consider ICD. There is a impression in the mind that CRTP the best device. So if the patient has no potential problem, we should do CRTP. CRTP has its own negatives also. Because ICD is not bigger, it has more failure rate compared to the ACD. So, and as is the longevity of CRTP is less, with a bigger device for pocket complications of the moment. It's a more complex device. There may be possibility of inappropriate shocks also that can further limit the quality of life of patients. So it's not always that CRTP is less compared to a better compared to CRTP.
So I think the call is that we have to go for CRT, no doubt. D versus P, it's a clinical experience, and along with finances, which we should decide whether should go for D or P.
Yeah, so I think if patient cannot afford CRT-D, and so we can do, like he said, MRI. Along with that, we can do some monitoring also, sir, in form of Holter and ELR, just to
Sir.
see if there are some PVCs or NSVT.
Exactly, sir.
Then
Honestly,
Yes.
basically not afford CRT, I don't think so bad.
Yeah, but I said the risk assessment for sudden death should be done. So based on that, we can take the decision.
So in your experience, sir, how many cases of DCMP in cardiac MRI was done and there was no fibrosis?
If you ask me last last 5 years, so in non-issue cardiology, my current almost 90% of my country.
CRTP. Okay. So correctly said, as far as guidelines are concerned, definitely LVF less than 35%, LV morphology, it's a class 1 recommendation for CRT. Now coming to the second case. Again, here's a case.
Just a minute, just to interview. So what is the, like, I think you had discussion last time. So what is the role of physiological pacing in such a case?
Once it's set to use CRT, then we have to see whether to use the conventional CRT or right now, because we don't have a lot of data, we see everybody talking about cases because we don't have random data. So that is the individual quality of data. Individual 4 cases have happened.
Yeah.
But the guidelines are still saying that not the patients have found. It's quite likely that it will become different. But the data is so we should continue, and right now, at least now, we are using this one for basic for patients who are either where we cannot get the vein bodies or the patients. The guideline won't come. It could be done only as a part of guideline.
It may not be considered to be a particular reason. And if it's not to be done, then
Exactly. Plus, if there is micro dislodgement also. So, if we have captured left bundle, very good QRS complex, post procedure, even if there's micro dislodgement, then the whole purpose of getting a CRT is lost.
Yeah, that is, but if you get the perfect placement, I think logically you said if you have the conduction if you do the conduction pacing, rather than putting a LV lead, it is superior than the LV.
Exactly. No, LV. I think what we can do, sir, we can go for CRTP in those cases, put a LV lead and put a left bundle or his bundle lead instead of the RV lead.
what it might happen. Like, I do that LVB and RV the question again is whether the LV is something because of lateral that or because of that. If the LV is something because of that, if it is dilated, then that is
So coming to the next case. So again, here's a case of DCMP with LV dysfunction, CVO, EF is 30%. ECG has right bundle branch block with QRS of 155 milliseconds. So basically a case of DCMP with right bundle branch block with a broad QRS more than 150 milliseconds and NYHA class 3. So what should we do now? So it's a little different case. Now the ECG has right bundle branch block instead of left bundle branch block.
So what is the QRS?
So 155.
155. So let's say last 2 aggregation process.
CRT.
Because the premise is that not everybody in RBP pattern will have that system. Because in NBPP, that pattern is not a mapping property, so they will be that system. But some patients in RBP also have that system. What we see on surface, may general RBP, but they may also have the condition today, which is not money for sponsor. So less number of patients respond, but they do respond. So we guide our patients accordingly that the chances of benefit are maybe not 80%, but maybe 60%. And not the class 2 indication, not class 1 indication. But because patients have already achieved whatever they can do in therapy, so they still like to go ahead with studying that whatever they have, they won't take it. But as if it's class 2 indication, if it is between 130 and 149 seconds to evaluation, that is class 2 indication. May be considered. But beyond 1 to 3 seconds, very chances
So, going by the evidence,
I would like to add a couple of things what Dr. Saxena said. Right bundle, more than right bundle. So, on the ECG, we have got axis, which does to LPP also. Considers CRT, and then there are two things. One is when you're implanting the CRT, on paper you see only the QLB. If the QLB is more than 100 milliseconds, sorry, more than 160 milliseconds, it means that probably the patient will respond because they have a more efficient component of left ventricular delay rather than only RBP. And if you don't have good QLB in that situation, definitely I will put in this patient, I will certainly put a left bundle pacing instead of RBP pacing along with this patient. And if it is a CRT, if suppose we are for CRT, in that case I do a lot of CRT in 4 weeks.
yeah, I agree. So if we go by the evidence available and guidelines available, he is a candidate, appropriate candidate for CRTD.
Yes, sir.
But I think he is a potential candidate for physiological pacing, particularly of hot CRTD or
Yes.
loud CRTD.
So probably maybe, in a couple of years, we
Yeah,
tend to
we
see
have
that
done a couple of cases of
Yes, sir.
wide right bundle branch block,
Hmm.
giving very good QRS, but
Yeah,
the
exactly.
clinical is still
So
to be seen.
yes. So the answer is CRT-D. Whether we should go for conventional CRT or physiological CRT, maybe in coming years we will come to know. So as Sir mentioned that we can.
Which is not again something for the not proven in many studies, so not used in that. But that is something that we do. Second, as I said, the capital will be important and still from your also that number is more than 90% of the
So coming to the next case, again, he's a case of severe LV dysfunction, AF of 25%, and ECG has QRS of 110 milliseconds, NYHA class 3 with normal angio. So severe LV dysfunction, QRS 110 milliseconds, NYHA class 3. Now, what should we do? So what is right for my patient? Severe LV dysfunction, 110 QRS. Normal angio.
So your options of devices, so your options of devices, so you see whether the candidate is not, whether there is Starlink or what people are saying, data, older, Thomas, older. Otherwise, this kind of thing, I would say straight away to heart. I don't see a people to work for, and then because we think and all, as shown in marriage.
And what about ICD? So is he a candidate for ICD? Yes.
So just the value by the guidelines. So but we will give it that proper guidance to the patient. So after the dentist trial, which showed no benefit in one of the meta-analysis said about 7, 8, or 9 based on the various trials. And what they have included is that there is about 20 to 20% reduction in mortality by ICD. So if we consider well, that's what I tell the annual mortality is 10% will come down to 8 or 7%, 5% will come down. So over 25% reduction can be achieved. So we can be very realistic and the guidelines still mandate that we suggest.
Yeah. So probably we should go for ICD and enroll him for heart transplant since he is in NYHA class 3. So QRS 110, he is not a candidate of CRT. Again, the guidelines also say the same thing in patients with DCMP. So this is basically primary prevention, LVF of less than 35%. And important thing is that he should be on guideline directed medical therapy, and expected life expectancy should be more than 1 year. So this is very important for all the devices. So his life expectancy should be more than 1 year. It's not like patient is in heart failure and getting a device and you will just save the patient life. So patient should be stable before implanting a device. So next case, so he's a 52 years old male who underwent pacemaker implantation 12 years back. And interrogation showed, end of life, and he needs a pulse generator replacement, and echo was done suggestive of 25% LV. So basically he's a candidate. I mean, the diagnosis becomes pacemaker induced cardiomyopathy, and he requires a pulse generator replacement.
Functional class.
Okay, so he's in functional class 3. Yeah. So in fact, sir, even if he's not in functional class, I mean, let's come to functional class 3 first. 2 or 3. Severe LV dysfunction, needs pulse generator replacement.
So already a pacemaker in place. So I would like to know right side or left side also, because there is also a catch. But yes, of course, if we go by the guidelines, the CRTD is the most appropriate answer, because sudden cardiac arrest is there irrespective of. But yes, though sir mentioned about Dennis trial, but that hasn't changed the guidelines yet. Yeah, it hasn't changed the guideline yet, but it has changed our practice to some extent, and uses of CRTP have increased. So again, the decision will depend on the patient's economic condition. And suppose if patient has a dual chamber on left side, I just would like to put a CRT, this LV lead, and change it with CRT. So that will be, pardon? Yeah. CRTD, yes. And then, of course, next I was coming to conduction system pacing.
One thing I just want to add, so you said that you should ask whether the right plan or different plan. The other important thing, you need to see the weightage of the week, because obviously the weight cases are very less in the week. Because the week is not in the project one, then it is like you cannot get a CSC as well as ICC, or you can recommend an ICC, so project of CRT. And these are very tricky patients because old people cannot get the MR, sometimes a lot of artifacts in the basic, so you cannot make a but we just reduce it.
Most of these old pacemakers, usually their lead is implanted apically. So if somebody has septal lead, does it make any difference?
That's again a controversial subject. It's very difficult to say whether that cycle is the lead and reduce the energy. In fact, often we have seen patients with dual chamber pacing.
Yeah, so if we are giving CRTD, that's a separate thing. But if we are giving CRTP, then maybe just changing the ventricular lead to a left bundle lead or his bundle lead is a better answer. Because if you think it is a pacemaker induced cardiomyopathy, so that is, as you mentioned, LBBV causing LV dysfunction. Yeah, you save a lot of money. Yes.
Yes, sir.
And sometime, the decision also depends on the age of the patient. Dying of a sudden cardiac arrest doesn't matter at the age of 85 or 80. There, the quality of life matters. But in a young patient, of course, I would be very cautious and try to put a CRTD.
Do you have any role of EP during the implant? Whether can it guide the therapy, whether you put CRT, D, or the
So the guideline says that CRT can be useful for patients on JDMT who have LVF less than 35% and are undergoing new or replacement device replacement with anticipated requirement of significant ventricular pacing. So according to guideline, is CRT, but I'm not sure whether actually functional class matters, because suppose he's in functional class NYHA class 1, then also I think the guidelines remain same. So maybe NYHA 1, 2, 3, I think maybe the guidelines remain same.
It's ejection fraction, if it's low.
Yeah, so he's
See,
definitely.
Medit CRT changed our mindset. With Medit CRT, if you are giving if there is wide QRS and LV dysfunction is there, even if patient is symptomatic and he has, particularly if has a indication for ICD, which everybody has, then CRTD is better. So here what guidelines says is CRT for CRT only, not that CRTP is indicated. Because you have to evaluate the patient for ICD separately, and if he becomes a candidate of ICD2, then you have to go do CRTD. And guideline is ICD for everyone who has below 30% or below. So it is always always remains CRTD. It is patient to patient what we can change a little bit.
And here comes the clinical experience. So there's a lot of options available for a particular patient: physiological pacing, CRTD,
Yes.
CRTP. Yes, sir.
Yeah.
Cost also matters.
Yeah, the discussion with the patient, ultimately it has to be the patient's choice because there is finite risk of sudden cardiac death.
So should I continue? One more. So let's come to this case. So last one. So he's a 50 years old male patient. He had MI and he underwent angioplasty around 6 months back. And after 6 months, he had unexplained syncope. And echo was done, AF was 40%. Now, how should we approach? So post MI and LV dysfunction, AF 40%. And he came with unexplained syncope. No documented VT at that time. I mean, obviously, unexplained syncope means that. Yes, sir. Yes, sir.
This is the MEDIT 1 population where EP study proved useful. And also like we should rule out vasovagal syncope in any patient of syncope. Second is you try to rule in arrhythmias by doing Holter and ELRs, and then comes the EP study. But if clinically it looks like vasovagal and head-up tail test is also positive, history is where if somebody has a micturition syncope, he won't give it.
So how many times, I mean, what is your experience of doing an EP study in these kind of patients? Do you frequently do these EP study?
I think if clinically it looks like a cardiac syncope, it doesn't look like a vasovagal syncope and a seizure, we should put an ICD. Because even EP study will not rule out, non-inducible VT will not rule out. Yeah, but if there was no syncope, then it is a different matter. But if syncope has already happened, then probably just want to rule out vasovagal. And if history is cardiac syncope, go for ICD straight away. There is nothing.
I think we should end the session.
So thank you, Dr. Kush. And we had wonderful discussion.
Yeah, very nice discussion with how
इधर आया नहीं. वो चलेगा, लेजर पॉइंट होगा, लेकिन ये क्या हुआ? Okay. So probably it is going to be the continuation of what we talked in last 15-20 minutes. And this is very, very important, like, certain cardiac death. And certain cardiac week is coming, like, from 25th September, the last week of September. So we need to do a lot of activities during that time also, because life is very precious and we try to save life of each and every patient. So how do you define sudden cardiac death or arrest? So the most important thing is a sudden death which occurs within 1 hour. So, if the patient is absolutely fine and he died within 1 hour, that is what we say is a sudden cardiac death. And the patient could be having a known cardiac or maybe unknown cardiac disease. We don't know. And believe me, like, most of the patient, when you counsel the family afterwards, so they have got a lot of prodromal symptoms like chest pain or fatigue or palpitation, maybe for months or maybe for weeks together. So that's very, very important. So this is how the chronology is. So prodromes are there, obviously patient, again in our setup in Indian subset, patient think that is a gas. So that's the main problem, and many of the people, they say like in a normal gas. I don't know what is normal gas. So chest pain, palpitation, fatigability, these things remain for months together, days to months. And then what happens, one sudden there's an onset of terminal event, abrupt change in the clinical status. It could be arrhythmia, it could be hypotension, it could be dizziness, and patient collapse. So there's a effective loss of, there's a loss of effective circulation and there's loss of consciousness. So that is what we say, sudden cardiac death. If the patient again wakes up, we say it's about sudden cardiac death. If it doesn't wake up, he's dead. So again, what is biological death is the failure of resuscitation, and if there is a failure of electrical, mechanical, and CNS function. So that is what we say biological death. Many times, my patient and the family ask, Doctor Sahab, you have written sudden cardiac death in your diagnosis. So how it is possible, because patient is alive. So then we explain like, this was sudden cardiac death, which is aborted. This is not a biological death. Biological death is a different thing. So what are the facts? So most of the victims, they do have heart disease. But what I said, like, they are being unaware of it. So, they don't know what exactly is happening. 75% of people die, they have previous heart attack, and almost 80% has got a signs of coronary artery disease. So this is the commonest thing. Coronary artery disease or MI is the commonest cause of sudden cardiac death. And 92%, even all over the world, 92%, they don't survive sudden cardiac death. And this is really very, very this thing. Every patient, 1% dying 90 seconds. So that's a real worrisome. So, all of us, we should know how to perform CPR, and we should try to teach how to perform CPR in all the common places. So what epidemiology say, 2/3 of the cardiac arrest, they probably were the first event, first event and first manifestation without any strong risk factor. So younger patient, 35, sudden death, we don't know. And many of times we think this is MI, but they die because of channelopathies and all those things. And less than 25% of the victim, they may have high risk markers based on arrhythmic or hemodynamic parameter. When they arrive because of the arrhythmia or hemodynamic parameters, probably they have got a very high risk factors. Another thing, what has been noticed, the sudden death more common in the mornings, early mornings, more common on Mondays and during winters. So that is what, again, the statistics shows. So what it says that once you're aging, like 45 to 75 years, that is the commonest stage of sudden cardiac death. But what we see in our clinical day-to-day practice, the younger generation are more sudden cardiac death than the elderly patient. And what I said, coronary artery disease is the most common substrate for underlying sudden cardiac death. And after MI, we say 40 days is more important. Trust me, 6 to 18 months. This is the most important because there's a rapid attrition during that time. And once that period is gone, it's not end of the world. Again, the same thing. After 2 to 5 years, the secondary delay, because of the remodeling of the heart, how the heart has remodeled, whether he has prevent the remodeling or not. So how it has remodeled and what is the state of the heart failure, it depends. This is very interesting slide, incidence and the total event.
So if you see the incidence in general population is the least, and if you see among the arrhythmias or post-myocardial infarction, the incidence is highest. But if you see the events, it's the exactly reverse. Like, general population, the events are the maximum and the arrhythmic subset is the less. Other things comes as a high risk group or a prior coronary event or heart failure and all these things. This is very, very important. So again, the common population, younger and the elderly, if you see by the age, so the channelopathies, the structural heart disease like hypertrophic cardiomyopathy or arrhythmogenic right ventricular dysplasia, Brugada syndrome, these are very common in a younger subset rather than coronary artery disease. And when the patient is advancing heart rate, coronary artery disease or idiopathic cardiomyopathies or valvular heart disease or granulomatous disease, these are the common subset of this thing. So these are, if suppose you are going with an advanced heart disease, almost like 10 to 25 years. So these are the most common factors. Coming to the gender difference, there's a significant gender difference. Among the men, 80% of coronary artery disease. In women, it is less than 50%. So in less than 50%. So what we see, like, Kush was showing all male patient with dilated cardiomyopathy. I was about to ask him, why not a single female patient? Because what we see, idiopathic dilated cardiomyopathy more often in women than the men. The other thing, like, valvular heart disease or channelopathies or congenital heart disease, long QTs are the things which are very, very small. But yes, male gender coronary artery disease, female gender dilated cardiomyopathy, and the other factors it comes. What is the Indian perspective? Again, if you see the incidence is 0.55 per thousand, that's quite high. This is the age what we see. And again, if you see the gender is 3:1. The men are more prone for sudden cardiac death than the women. And this is very alarming. The survival rate of sudden cardiac arrest in India is less than 1%. So that is what we need to address, and we need to save these patients, how we can save this patient. What are the risk factors? Which are the patient of sudden cardiac death? So there are certain genetics, coronary artery disease risk factors, some arrhythmic risk factors, nutritional, psychosocial factor. This has become very common nowadays, and certain biomarkers. So when we are talking about the genetics things, it could be long QT or a short QT, could be Brugada, or it could be catecholaminergic CPVT. Structural heart disease, again, hypertrophic cardiomyopathy is very, very common, which produce a lot of sudden cardiac death, or ARVCs. And certain drugs which increase the long QT or electrolyte disturbances, again, they can produce sudden cardiac arrest. Among the risk factor for sudden cardiac death and coronary artery disease, there are modifiable, non-modifiable, we know. Non-modifiable, which God has given, nothing can do, male gender, genetic, age, or family history. Yes, smoking, hyperlipidemia or dyslipidemia, obesity, sedentary lifestyle, you can change those. You can control your blood pressure, diabetes, so definitely you can reduce your incidence of sudden cardiac death. What the Framingham study showed, it shows that there was 2.8 to 5.3 fold increase of sudden cardiac death in patients with coronary artery disease. And the most important factor is the LV dysfunction. So rule of thumb, LV ejection fraction less than 30%, always counsel with the family and patient that he is a single most predictor of sudden cardiac death. And if you see here, 7.5%, if the ejection fraction is less than 30%, 7.5%, when it is more than 50% is 1.4%. So if you're asking single risk factor, LV function is the most important thing. Arrhythmias, again, when you're performing a general health checkup and you're performing treadmills, see whether any inducible arrhythmia during the exercise or recovery phase. If more arrhythmias on the recovery phase, that is more important. That suggests more chances of sudden cardiac death. And if you're doing a Holter or a ELR, if there are PVC burden more than 10 per hour, that again increase the risk of sudden cardiac death. ECG is very important. Always look and see what are the markers you can see. What is the resting heart rate? If the patient resting heart rate remains 110, 120, always tell them that this is not good. If the QRS duration is wide, again, it's not good. If you're performing a treadmill, see the recovery, whether the pulse rate is coming, the heart rate is coming down immediately at 1 minute or 2 minutes, less than 12 or less than 22 or not. If that is not coming persistent high, again, it's a significant. Prolonged QT, and we used to say, like, early reparation syndrome, these are benign. Now they are not benign. These are channelopathies. So if you see this kind of things in ECG, again, counsel the patient, get genetic counseling and see what exactly you want to do. Nutritional, again, alcohol is one thing. If you're taking excess of alcohol, sudden cardiac death goes up, probably because of cardiomyopathy. Moderation is fine. Magnesium diet you should take. And most important thing is the polyunsaturated fatty acid. If you take polyunsaturated fatty acid, it's pretty good. This has become very common now. Depression, anxiety, social isolation, and psychological stress. There is a rat race in all the professions. So psychological stress, again, is very, very important. They all increase the risk of sudden cardiac death.
Certain biomarkers, what Sanjeev Sidana was saying, NT-proBNP, if the LV ejection fraction is less. This is a very important marker to risk stratify who are at sudden cardiac death or not. HSCRP, which is very specific, you can see. IL-6, you all came across in COVID era that, IL-6 again is an inflammatory marker. You can see certain metabolic parameters, markers also can tell you. Business light, but again, what it says, it's a coronary artery disease or a congestive heart failure. The preceding factors are diabetes, blood pressure, smoking, dyslipidemia and all. And what they are doing, they are doing fibrosis or scarring and producing LV dysfunction. And that is what the substrate, and that triggers arrhythmias. And that is why patient land up in a sudden cardiac death, and how you can prevent that is the most important thing. What is the pathophysiology? What say is mostly tachyarrhythmias, VT or a VF. That is the most important thing. And re-entry is the most important mechanism at the tissue level. If you're talking about the cellular level, it's a different thing, because there is increased excitation as well as decreased repolarization reserve of cardiomyocyte that initiate the VT-VF. It could be automaticity or it a trigger. These are all physiological kill. And many a times, patient is brought dead and you have got a pulseless activity or a absolutely straight line or a bradyarrhythmia. It means that probably patient was in VT and that has resulted into pulsal electrical activity. Pulsal electric activity only happens if there's a rupture after MI, there's a rupture of the heart, then only there will be this thing. So what are the other things? Risk factors, coronary artery disease. If you have got a previous cardiac arrest, patient has syncope, like what Kush was showing, syncope with the coronary artery disease. They are very high risk for sudden cardiac death, and what Makkar was saying, put an ICD, I agree with that. If patient has got previous myocardial infarction within 6 months, LV ejection fraction 30%, ectopics, lot of ectopics on Holter or ELR, that is very, very important. DCM, non-ischemic, again, the most important thing, whether if the patient has got a syncope, they are again a candidate for sudden cardiac death. And if the patient is having recurrent admission for heart failure in DCM and requiring inotrope support, these again are high risk for sudden cardiac death. These are the 3 trials which came, MEDIT, MUST and MEDIT-2. And they all say, whether it's a ischemic or a non-ischemic cardiomyopathy, there are certain criteria where you really want to give an ICD and whether you want to give or not. MEDIT was the only one where, the EP study, where EP study was performed. But again, the role of EP study in inducing tachyarrhythmias are some limited thing. This is very important, family history, hypertrophic cardiomyopathy, any hypertrophic cardiomyopathy, unexplained syncope. If the patient, you're performing a treadmill of a hypertrophic cardiomyopathy patient and he has got a sudden drop in the blood pressure, or you're getting a Holter ELR in which you're showing a lot of non-sustained VT, or you're doing a very good echo and seeing what is the thickness of the interventricular septum. These are the factors, and you should give an ICD as a primary prevention to HCM patient. And if there's a family history of sudden cardiac death, always give an ICD to HCM patient. Valvular heart disease, again, LV function is important. Any valve replacement within 6 months or a syncope or uncorrected aortic stenosis or mitral stenosis, those are the important things. Long QT, we have already spoken. Family history or of sudden cardiac death, that's very, very important. If the patient has got bilateral deafness, so this is long QT one, they have got no more chances of a sudden cardiac death. What are the arrhythmias which precede sudden cardiac death? Yes, VT is the most, 2/3 of the patient, they have VTs. There could be some cases of primary VF and polymorphic VTs. They again, because of the structural heart disease, it could be long QT or any other thing. So what is the recommendation for prevention of sudden cardiac death right now? Any cardiomyopathy or post-MI patient who has undergone a PCI or a CABG, if suppose a patient has undergone a PCI or CABG, you have to wait for 3 months. You can put them on a wearable jackets. If post-MI LV ejection fraction less, wait for 40 days and then evaluate whether you want to give an ICD or not, or any other cardiomyopathy LV function is less than 30. Most important thing, refer these patients to heart failure clinic because they need a lot of evaluation. And these are the subset of patients in which you can certainly prevent sudden cardiac death. So at 1 month, 40 days, 3 months, assess what exactly is happening and then see to it what exactly is happening. In the ER, this is the scoring what we do. If the patient is brought with a sudden cardiac death, if his systolic blood pressure is more than 90 or the resuscitation time is less than 25 minutes or he is a neurological responsive. So if the score is 3 or more than 3, it means that there are chances of almost 90% chance of neurological recovery and there's 80% chance that patient will survive at the time of discharge. I think I'll stop here. I'll take your question. Thank you for your attention and patience listening.
Thank you, Dr. Anupta, for a nice presentation. So, What do you advise? Like, most
forever. That is what, and particularly if there's any surgeon, I don't feel offended. The surgeons never explain that. They say like, the patient LV function is 20 and they do a surgery. They will say that they have cured everything. They will never say that the LV function is still 20%. Yes, post MI, first 40 days is important. After 40 days, if the LV ejection fraction is less than 30%, I suggest all my patients for a AICD as a primary prevention, according to the MEDIT 2. If the patient has undergone a intervention, either a PCI or a cabbage, I wait for what is the LV function. If the LV function is borderline between 30 and 40, I try to do some other alternative, like, I try to get maybe ELR, a Holter, or a signal average ECG, or sometime a cardiac MR to risk stratify what are the patient who can, like, what we say 1.5 prevention of sudden cardiac death. So if you have got a indicators or patient has got a history of syncope, if these are the indicators, markers, certainly I will give an ICD. If these are not the markers, in that case, I'll keep a very close follow-up and follow those patients in my outpatient clinic.
I think that's the most important thing. Any other question?
Sir, about 10 days previous, one patient come about 5 a.m. early morning, complain of dyspepsia, burning sensation, substernal pain. I just do ECG, there is normal. And then we advise test CKB, there is not possible. And after the 1 hour, he died. After the half an hour, patient is died, about age 25. What we should this type of patient?
Very important, like, what you said, the history was so typical. So, you may not get a ECG changes on
No, sir,
the
no
first.
ECG changes.
So that doesn't rule out the patient is not having acute coronary syndrome. So that's very, very important. The first thing which you can diagnose an acute coronary syndrome is to get a echo done. You can back, serial ECGs, echo, enzymes. And again, I tell you, the most important thing is history physical. If you do a good if you take a good history, most of the time you will diagnose correct.
Yes, sir, there is no history of any sudden cardiac death in his family. Just after the half an hour, he died during the testing.
Yeah, so don't send the patient back. Like, you will,
But don't worry, back, sir. Just opposite my lab, just near the my clinic.
So if suppose this is a hospital setup, like, if you have a defibrillator, you will be able to revive this patient for sure. He should not die.
It means just patient come and admit it. Continuous monitoring.
So probably the patient may not be hooked with the monitor, and somebody may not have seen what exactly has happened. Otherwise, it's very difficult. Like, in hospital, patient dying suddenly without knowing what is the cause is something is very serious.
Yes, sir, many type of patient come just for chest pain. Which type of patient you must admit? may drop by negative in early hours.
So this is what I'm saying, like,
And
if H3 is very typical, you can repeat troponin again after 4 hours. Nobody is saying no to you for that.
I think this patient needs an immediate defibrillation. That is the most common cause. So thank you, Dr. Anup Gupta, and we'll invite Dr. Anil Saxena for the next talk, like ICD therapy. How far we have come and new advances in the ICD therapy. I think this is also going to be interesting talk. So what is related to sudden infection?
Till his slides are ready, one thing one should be very clear in the mind of physicians, irrespective of the age.
We start normally, the physicians, normally when the patients complain of the symptoms, normally we start the treatment, but that is too late sometimes, There's a classification of heart failure, stage 1, stage A, stage B, stage C, stage D. So stage C is when the symptoms are there. But before that, we have got a stage A and stage B. Stage is that when any patient have got a risk factors like hypertension, diabetes, obesity, CKD, these patients have got risk factors, and you start these treatment, get these risk factors noted as early as possible and start the treatment for these risk factors. Even these patients may not have any functional or echocardiographic, parameters for heart failure. Similarly, in the stage B, patient can have a, pre-heart failure symptoms. Patient may not have any symptoms, but if you do an echocardiogram, you can pick up those symptoms, functional. One should have a checklist, for any patient. You should have a checklist that at least for any heart failure patients, you start all these drugs. And especially nowadays, though, so we have now Dr. Anil Saxena. Well, he'll be going to speak on ICT therapy, new advance.
Yeah, thank you. Thank you, Mr. Chairman. And I must begin by thanking Dr. for inviting me to this wonderful conference. So I will be therapy, how far we have come and what are the future directions, what are the current recent technologies that we have. So this will be a continuation of what we have been discussing earlier. And ICD, as we know, is a technology that can detect arrhythmias, and it's implanted inside the body. It has 1, 2, or 3 wires which connect to the lead, depending on whether it's a single chamber ICD, dual chamber ICD, or biventricular ICD. And it monitors for arrhythmia for continuously. And whenever it detects a life-threatening arrhythmia or potentially life-threatening arrhythmia, it delivers therapies in the form of overdrive pacing for ventricular tachycardia and defibrillatory therapy for ventricular fibrillation. Now, when we started, initially the indication was for those patients who had survived a sudden cardiac death. So somebody has a cardiac arrest, he was taken to hospital, and we found that patient is in ventricular fibrillation, he was defibrillated, and that was the original indication for ICD, and that continues to be #1 in all the guidelines. Then came sustained ventricular tachycardia, that patient who have hypotensive ventricular tachycardia with sweating, dizziness, etc. And we implant an ICD in them to treat this arrhythmia by overdrive pacing or shock. That was the second most important indication. The third indication came when patients had syncope, and which could be presumed to be because of ventricular tachycardia because of pre-existing heart disease or past history of acute MI, as the same case that was discussed. And in this case, if we induce ventricular tachycardia, that was another indication that was added. And then came the most widely used indication, that is primary prevention, because what was realized was that these are very few cases who could benefit from ICD therapy. Patients who have a problem like ventricular tachycardia, etc. But first of all, we could not save all of them, and then there were very minutiae of those patients who were vulnerable, and we had to wait till they have a VT. Only then we would implant ICD. So that was not the right approach. It was thought that we should try to be more proactive and look for patients who are susceptible to have VT and VF rather than those who actually have, and benefit them with ICD therapy. That was the premise, because what happens is once somebody has a malignant arrhythmia, you cannot treat. I mean, you cannot reach the patient within a few minutes. So primary prevention ICD was considered and implanted and became a routine indication for low ejection fraction patients who had symptomatic heart failure. Asymptomatic, usually it was not indicated, but class 2, class 3, and class 4, it was indicated if the expected survival was more than 1 year. But what has been seen of late is that, so this has been happening for last 25, 30 years, that we have been implanting a lot of primary prevention ICDs. But the recent data suggests that the utilization rate of these ICDs is very low. So maybe 1 or 2 or 3% patients end up using the primary prevention ICD. And that is also partly because the overall mortality of heart failure has come down, of asymptomatic LV dysfunction patients has come down from 7 to 10% earlier to about 3 to 5% now. So the ICD obviously has less, it becomes less utilized because there are so many other medication and other therapies which are competing for mortality reduction. And this is a paradox of ICD uses in the same, we have been discussing this point earlier, that most of the deaths occur in patients who have ejection fraction more than 35%. So that's why we are moving from vulnerable ejection fraction to vulnerable patient. Rather than focusing totally on the ejection fraction of 35% or less, we are now looking at ways to identify patients who can have sudden cardiac death and target our ICD therapy to them irrespective of left ventricular function. And towards that, there are so many things which are being done. One, of course, is the MRI, as we have been talking about, looking at this scar. So even patients who have ejection fraction more than 35% and have certain other markers, both on ECG and imaging, which can indicate that these patients are susceptible to sudden cardiac death, we should consider ICD therapy on them. So that is one future direction which is happening very rapidly, that we are looking at completely new ways of risk stratifying for sudden cardiac death rather than depending on a symptomatic LV dysfunction of ejection fraction 35% or less. So there are clinical markers, there are genetic markers, there are imaging, including like strain echo imaging, SPECT, PET, cardiac MR, electrophysiologically, and then artificial intelligence is now playing increasing role. So data of patients is being fed in the computers, millions and millions of patients, and we are expecting to find patterns by the artificial intelligence of patients who suffer sudden cardiac death. So that will eventually help us in a evolving of a multifactorial kind of algorithm, which will detect patients who are more likely to have sudden cardiac death, and they can benefit from ICD therapy irrespective of their left ventricular function. So that is something very, very important. Biomarkers, etc., they also play a role. So that is one thing which is now the thought which has evolved now, is that we should target therapy rather than depending only on ejection fraction. Second important thing is, once you decide to place an ICD, which ICD to give, single chamber or dual chamber? That's a very commonly asked question. And there is no easy answer to it because both have their own advantages and disadvantages. Single chamber ICD, they're less hardware, so less complications. No atrial pacing is of course a disadvantage, and no atrial sensing is also another disadvantage. So atrial arrhythmias cannot be recognized by the single chamber ICD. There are some algorithms like Medtronic have an algorithm to detect atrial fibrillation, but which has been quite validated, but that is one disadvantage with single chamber ICDs. But they also have higher longevity compared to dual chamber ICDs. The main advantage of dual chamber ICDs is that they have an atrial lead also, which can be used for atrial pacing in patients who have symptomatic bradycardia. And because of atrial lead, they have atrial sensing, so they can better detect the atrial arrhythmias and find out the arrhythmia burden, etc., much more accurately. So that's the advantage. So we have been debating, but largely because of the longevity and simplicity and cost factor also, we have been using more of single chamber ICDs than dual chamber ICDs. But of late, we have another choice available, which is DS technology from Biotronic, which has a couple electrodes inside the atrial portion of the single chamber lead, which basically can sense the atrium. Like you remember, there was a VDD pacemaker, which is very less often used nowadays. With a single lead, you can sense the atrium and pace the ventricles. So it's the same technology here, that it has a electrode couple in the atrial portion of the lead. So with single lead, it can detect atrial arrhythmias and find out the arrhythmia burden, etc. Very accurately, and has been quite validated now that, as we can see here, this is a single lead, but it has an atrial sensor which can look at the atrial arrhythmia, and so this is the atrial rhythm and the ventricle. Now we know that it's something of fundamental importance because atrial fibrillation can be asymptomatic, and the ASSET trial showed us that asymptomatic atrial fibrillation is as bad as symptomatic atrial fibrillation, and there is always a virtue in finding out if your heart failure patient is having asymptomatic atrial fibrillation or not, because not only it dictates the prognosis, but we have to give anticoagulation therapy to these patients. And the results from the COMPASS trial also showed that monitoring, whether home monitoring, was very useful in detecting asymptomatic atrial fibrillation. So this DX technology will work like home monitoring only for these patients because they already have an ICD, and having another atrial sensor in the atrium will help detect the atrial fibrillation more accurately, and that has been validated in the studies. And it can also be utilized for giving CRT. So you can have a two-lead system whereby you can have just the one ICD lead in the ventricle and one lead in the left ventricle, and the atrial sensor is there. So it will sense the atrium and pace the ventricle, but it can give biventricular pacing with only two-lead system. And it is also MRI. The other things are like home monitoring and MRI. They are all standard nowadays. Another new technology which has come is subcutaneous ICD, because it has been found that the main problem with the ICD therapy relates to the placement of lead inside the heart. Whether it's acute complications like hemopericardium or pneumothorax, or whether it's a chronic complication like lead failure and lead endocarditis. And the problems are, if a lead gets infected, we have to remove it, and it's really very, very difficult to extract leads. It is fraught with danger and complications to the patient. It's very expensive as well. And venous occlusion is another problem with the placement of the lead inside. So all the problems of ICD therapy are related to placement of lead inside the body. And subcutaneous ICD bypasses this problem. So we have the generator in the axilla, and we have a lead tunnel along the subcostal margin, and the coil is in front of the sternum in the parasternal area. So it has this multiple vectors. There are two sensing electrodes at the tip and at the both sides of the coil. So they generate three vectors: the primary vector, secondary vector, and alternate vector. The device can automatically sense which vector is the best and utilize it. So the advantage of subcutaneous ICD is that there is no need of venous access. The entire system can be placed outside the thoracic cage in the subcutaneous space. It avoids lead endocarditis completely, and also the problem with the lead extraction. It is better suited for children compared with the transvenous. It saves both the pectoral areas for future use, and so that's a very big advantage. And in women, it can work with the cosmetically also better. And the data, it has been in use for last decade, and the data suggests that it very well fulfills the promise that it was created for, that lead complications are much less. That is only 0.14% compared to 1% with transvenous ICD. And the other things are common, like infection rate, the pocket infection is similar, and inappropriate therapy is also nowadays similar. Initially, it was higher, but now with the latest, this is the latest trial, Praetorian trial, which again showed that the lead complications and the device-related complications are much less with the subcutaneous ICD. And the inappropriate shocks are more or less similar as compared to the transvenous ICD. And that's another data from multiple trials, which has shown that the inappropriate shock rate from the subcutaneous ICD has decreased from 13% to now around 3% per year, which is very comparable to transvenous ICDs. As far as the guidelines are concerned, both the American and the European guidelines, they now advocate utilization of subcutaneous ICD in patients who do not require pacing or CRT, or they don't have a pre-existing monomorphic VT that requires anti-tachycardia pacing to be available. So these are the three things we have to exclude: that patients should not have bradycardia, patients should not have a need for CRT, and patients should not have a monomorphic VT that requires termination by ATP. Of course, now the work is going on to have a pacing available through subcutaneous ICD utilizing a leadless pacemaker, and that can also give CRT possibility also. And there's another subcutaneous ICD. It's not, they call it EV-ICD, extravascular, which is not entirely subcutaneous. There, the coil is placed under the sternum. That is from Medtronic. It's called EV-ICD, which is yet to come into the market. But that is something which is again very promising. So these are some of the new things, and other things are like home monitoring, etc. They are different, but this is some new. These are some of the new development that have come in the ICD space. So I'll be very happy to answer if there is any question. Thank you so much.
Thank you, Dr. I just have a question back to this technology. That both the story and practical
Yes, yes. So I don't think CRT using DS technology is an ideal situation, because one thing is that the sensing can never be 100%. And second thing is that it cannot pace the atrium if there is a need. And many patients in the night, all of us drop the heart rates to 40, 40, in 40s and 50s. So it won't be able to pace the atrium. But where we are considering single chamber ICD, and for the benefit of cost and longevity, their DX technology is really good, that it offers us a way to monitor for atrial fibrillation, atrial arrhythmias, and it can to some extent reduce the inappropriate shock rate as well by diagnosing the arrhythmia better. Thank you. Subcutaneous, yes, it's available last many years. Thanks. In fact, I've replaced in one patient. So we used planted about 7 years ago.
Thank you.
Kindly pay attention, please. After 2 minutes, we will start our next scientific session. So request to all of you, please take your seats. Thank you. Once again, very good morning to all of you and a very warm welcome in JHRS 2021 Day 2 Scientific Session. After post-tea, I would like to invite for the next scientific session on Thank you very much, Dr. Harpreet Galhotra sir and Dr. Ruchi Gupta ji. Now I would like to hand over scientific session to Honorable Chairperson to proceed further.
Is by Dr. Jitendra Vakar about pacemaker without the leads, and then next talk is also by Jitendra about new generation Bluetooth devices for pacing in heart failure.
Thank you, Harpreet. Good morning. Welcome once again to JHRS. Actually, the next talk, this talk actually is supposed to be delivered by Dr. Vinita. So I'll do both of them together and then we can have some quick discussion. So leadless pacing, is it a reality? Yes, we have been doing it consistently last 4 years. It was probably 2017 we implanted our first leadless pacemaker. So this is how pacing technology evolved from a large portable battery to a small pacemakers and then to a leadless pacemaker. So this is how it looks like, the so-called Micra by Medtronic. This is a little bit bigger than a capsule with some these nitinol tines on its tip, which keeps it engaged into the endocardium. So this is how it is implanted. This is at the RV apex, but this can be implanted on RV septum. So most of the cases we implant on RV septum. So this was clinical trial where 2,667 patients were included. And this is actually working like a single chamber pacemaker, but now it can be used as a dual chamber. I'll come to that. So what are the potential indications? Where is that you don't want the leads or you can't put the leads? For example, bilateral subclavian vein stenosis, where you have no option but to put a leadless pacemaker. Pocket infections, bilateral, intolerance to titanium or nickel titanium alloy, which is not uncommon, high risk of pneumothorax and other lead and puncture related complication like severe COPD, very aged frail person, and CKD patient, particularly on dialysis, who have a very high rate of pacemaker endocarditis. And it can be eventually, as the guidelines say, that this is a single chamber pacemaker. So wherever you think that single chamber pacemaker can be implanted, we can implant a Micra also. So particularly useful when there is AF with bradycardia, where a single chamber is enough. Intermittent or rare need of pacing, where patient will not be dependent on the pacemaker, and advanced age with limited activity and frailty, which we say is an indication for leadless. So these are the trial indication where, most of the chunk was chronic AF with bradycardia, where they thought that single chamber is enough. In our cases, the indication mostly were related to this all is because of the atrial fibrillation, and this is because of infection. So I put together, I have done around 47 cases in my lab and as a proctor, where these are the indications. atrial fibrillation, infection, venous access issue, old fragile patient, prosthetic tricuspid valve. I implanted 3 leadless pacemakers with prosthetic tricuspid valve. Morbidly obese patient, there was one 130 kg patient where it was, difficult to find the subclavian lead. So I'll put a few examples where I implanted Micra. One was 85-year-old gentleman, infected pacemaker and lead. So he didn't want another pacemaker with a lead. 89-year-old fragile gentleman with left hemiplasia and contractures with small barrel-shaped chest with complete heart block. So this was my first patient who was actually dependent on temporary pacemaker. So it was not avoidable, pacemaker was not avoidable, but because of his frailty and he was not even able to lie down flat. And chest was barely having any muscle and fat. So bilateral infected pacemaker site, there was 65-year-old gentleman, 85-year-old gentleman post CABG and AVR, intermittent complete heart block and CKD, 65-year-old lady with bioprosthetic tricuspid valve with failure of epicardial pacemaker already once. So these were our few initial indications. So I'll just put some interesting scenarios. 70-year-old gentleman admitted at another hospital had temporary pacemaker and he was waiting for permanent. During permanent pacemaker, on table he had pneumothorax and then he was shifted back with an intercostal tube and pacemaker was deferred. When he was shifted to ICU, he had cardiac tamponade because of the temporary pacemaker lead. So every possible complication of a lead happened to this unfortunate patient. And then he had to be operated for cardiac tamponade. And during surgery, the temporary epicardial pacing wires were put in and he was on that. So now patient was very much afraid of getting a pacemaker. So he said, no more surgeries, no, I don't want a pacemaker, but he was dependent on temporary pacing. So he was shifted to our center and we put a leadless pacemaker. So this is one example where, I don't know if it will run, yeah. So we put in VVI in an infected pacemaker. When pacemaker was removed, but lead was not removed, and then lead had a sinus and repeated dressing and all that stuff. So we removed the lead through femoral vein by snare, and I was afraid of the fact that the leadless will get dislodged, but this is how it happened. It was on septum. And you see that septum is being pulled by the lead, but leadless pacemaker remained in place. So once it is well stuck in the endocardium, it generally stays. And in all my cases, I don't find any dislodgement or significant change in thresholds. Yeah, so this was a lady who had mitral valve and then tricuspid valve replacement and then epicardial pacemaker which failed and she had a syncope. So we implanted, this was my first case when I implanted through prosthetic valve, but it went on smoothly. It is a 27 French sheath, but the valve size was 32, so it was fairly okay. So there was another patient in Chennai who was waiting for a heart transplant, young lady, 24-year-old female, CHD with an Eisenmenger and waiting for a heart transplant, developed complete heart block and they decided to put a leadless pacemaker. I went there. In the morning 6 o'clock we took the case and I found that she had interruption of IVC and azygous continuation of IVC. So this was the course of my wire. This is how I had to go to the RV. So I was not sure whether this sheath can reach to RV like this. So what I did was I took a decapolar flexible catheter which was exactly the length of Micra sheath and I took there. So it was complete AV canal defect. So after going to ventricle, I didn't know whether I am in the left ventricle or right ventricle. So by pacing and by various LO, RO and left lateral this thing, I decided that this is RV and then we implanted. So recently I have done only one Micra AV. So it's a beautiful concept that the same, the Micra which is implanted in the RV senses atrial contraction. So basically, every pacemaker has a sensor which senses physical activity and increases the rate. So that capsule is lying in the right ventricle, but it is sensing the atrial contraction and it is coupling the ventricular contraction to that atrial contraction. So this is how it maintains synchrony. So this was a very unique scenario where patient was 72 years old, had pacemaker in 2014 for CHB. He developed CKD later. He was put on maintenance hemodialysis. He had then unexplained fever, diagnosed as lead-related endocarditis. We were not sure. Then we got a PET scan done, which showed the increased activity at the lead tip. So we decided to remove the lead. So now it can be done either with surgery or percutaneously, but the size of the vegetation was small, less than 10 millimeters. So we decided to remove it percutaneously, and we used that tight rail gun technology to remove those leads. So after removing those leads, patient got asymptomatic, fever was less, counts, those were 40,000 before removing the leads, came back to 11,000. And then we decided for a Micra because he has to be dependent on hemodialysis for some time and he has crossed the age of renal transplant. So we implanted a Micra AV in this case. So this was our first Micra AV lately. So future of leadless technology, AV synchronized pacing Micra AV, which is not a future actually, it is a truth now. CRT and duo of leadless pacemaker with a subcutaneous ICD. So as Dr. Saxena told about subcutaneous ICD, it can shock, but it cannot pace. It cannot provide anti-tachycardia pacing by pacing at a higher rate, and it cannot take care of complete heart block or bradycardia if it happens after a shock. So what the leadless pacemaker will do, it can deliver ATP and take care of bradycardia. And subcutaneous ICD can provide a shock and there would be no lead as such. Thank you very much. So, shall I continue with the Yes. Yeah. There are pacemakers available for them who have allergy, but they are made on order by industry. So now we have alternative as Micra. So I would say that this is a good, at least a single chamber pacemaker. Synchrony, AV synchrony can be maintained in trial cases also 60 to 70%, because on higher rate of atrial contraction, it is difficult to maintain the synchrony. But at lower rates, synchrony is managed beautifully. And our patient is maintaining good AV synchrony because he has a rate of 70, 80. Shall we move to another? Yeah. Okay, so a little bit about smart devices, Bluetooth enabled devices. We have now pacemakers by Medtronic and heart failure devices by Abbott, which are Bluetooth enabled, and they are synchronized with a mobile, which is downloaded in the patient's own mobile or the relative's mobile, and patient himself can keep a track and he can transmit the data to clinicians' office if they can manage, or right now the industry is managing itself But eventually the plan is to make clinics in pacemaker implanting center only. So basically the healthcare is moving close to the patient. There are a lot of mobile devices like mobile ultrasound, on bedside blood testing. Then this Apple Watch can keep a good track on your heart rate. Then COPD patch, home monitoring for device patients, and Bluetooth enabled NIVP monitors. So we are basically moving close to the patient. And what happened after COVID is that people are now, moving to the virtual health. What used to happen, what conventional practice is that we implant a pacemaker and then patient has to come periodically to get checkup for the pacemaker. Then he travels, comes to the hospital and gets his pacemaker checked. Now, if there is a major issue with threshold and patient develops bradycardia, syncope, he will present in between also. But for minor things like changes in the impedance or, for example, presence of atrial fibrillation or any other issues, he will not present to you. He will only come after a certain period of time, and these things can be missed. But now, then came the remote monitoring. So first the remote monitoring came as a separate mechanism where patient was given an instrument which can take the data of pacemaker and transmit to the server via radio frequency method or by the mobile networks. But now now comes the Bluetooth. So this is how it works. So basically, there can be device management. Program parameters can be seen. Actually, there no programming can be done yet by the mobile, by the telemetry. But yes, interrogation can be very well done by the telemetry. So main advantages are the battery life, and if patient is delivered any shock, then we can see what happened. Then device-related centered management, heart rate, atrial fibrillation detection is very important part of remote monitoring. Then patient can be contacted after having this, and heart failure management. There are some parameters which are shown in pacemaker interrogation report that patient is developing pulmonary congestion. So it is measured by the impedance. So if there are wet lungs, the impedance reduces. In dry lungs, the impedance increases. So as I told, we are shifting to virtual health, and these are so even 2015, HRS expert consensus statement came on remote interrogation that any pacemaker, any patient who is being given a pacemaker, class 1 recommendation, any patient who is being given a pacemaker or heart failure device, besides the one annual visit to the clinic, he should be offered a remote monitoring. Why? Because there is 50% low risk of all-cause mortality, at least in ICD patient. This is surprising. 50% reduction in mortality in ICD patient, 27% reduction in all-cause mortality in all devices, 36% reduction in cardiac or device-related emergency department visits, and 66% reduction in hospitalization of AF or stroke. So that's what I was telling, that finding atrial fibrillation in remote monitoring, putting the patient on anticoagulation can save a stroke. So this is the best utility I also feel in my day-to-day practice of remote monitoring. So those who are more adherent to their remote monitoring, what happens is people buy the instrument, people go home, but they don't take care of it. They don't transmit the data. They don't interact with their mobile app. So they should be educated, because if they want to take benefit, they need to transfer the data. So there are many barriers, money, then, doctors being not very tech friendly like I am. So, but I keep on trying to improve myself how to do all this stuff. But technology is obviously one limitation we all have as doctors. So these were the remote monitors being conventionally used till now, and now we have moved very recently within last few months to these Bluetooth enabled devices. So this is again, so this kind of summary we get on a mobile app. You can transmit this kind of summary where everything, thresholds and parameters and any event happen, that can be seen on this summary. So basically that this Abbott app is very interactive. It keeps on, it has an engaging activity, how much exercise you did, just like other health apps, that also it does. And it gives alarms also to the patient, red alerts that when he should transmit and contact his physician. So most of the patients are strongly engaged with their. So what you can get, a fast pass summary, diagnostic summary, episode summary, and obviously EGMs to support your diagnosis. So it is basically whatever I can interrogate when patient comes to my office with a WAND, with a programmer, same information I can get when patient is at his home and is transmitting via the other methods or via Bluetooth. But Bluetooth is obviously more convenient. It doesn't need to carry any other instrument, and your mobile is with you always wherever you go. But the other transmitters are kept at home, bedside. So this is like a record of my patient when I access to the app. This is how my patients are shown, that whether they are connected or not, and how many transmissions were done. So this is how I find. If I click one, I'll go into the detail of that particular patient. So this is a very interesting device. Yesterday also was mentioned in one talk that a small chip-like device which can be used for diagnosis. For example, if patient has a repeated syncope, say once in 3 months or once in 2 months, then Holter will not give you anything. And pocket ECG can also be used for a week or two. Then what to do? So these are implantable loop recorders. These conventionally called ILRs. And this Abbott thing is called Confirm RX. It's very small, thin chip which can be, it's actually loaded in a syringe kind of thing, and it can be implanted on OPD basis with an injector. So this I did a couple of days before. The patient is lying in my pacemaker dressing room, and this is a syringe kind of thing. We just give some local anesthesia, put a nick in the at fourth intercostal space, keep the nozzle of syringe in and push the chip. And chip goes inside the skin, and then we just give one stitch or just a band-aid or any healing spray can be enough for that. And this can record the heart rhythm for 3 years. It is battery driven, for it can record for 3 years, it is Bluetooth enabled. So the data can be accessed by us anytime. So even if he has syncope after 2 months, 3 months, 6 months, 1 year, then we can record. So basically this particular patient came from Kota to me. I think he was sent by Dr. Suri sir only, he is sitting in front of me. So basically it was not a vasovagal syncope. I was sure that this is a cardiac syncope. Something is happening because it was typical stroke Adam. He will just fall down and within few seconds he will get up. So neurologists say you don't have anything from my side, and Holter didn't reveal anything. QRS is also narrow. So let's see what we can find out. Maybe in the next conference I'll give you the result. We have implanted ILRs, but those ILRs have to be interrogated when patient comes back to my office again. But this one is Bluetooth enabled, so patient is always in the touch. So again, now these were Bluetooth devices, heart failure devices. Medtronic has beautiful technology of Bluetooth pacemakers. So these pacemakers are not the similar pacemaker as before. They have been redesigned for a Bluetooth, low energy Bluetooth. Basically, this Bluetooth technology doesn't affect the battery life, interestingly, because it uses very low energy. And there is encryption technology. These are not hackable. those other transmitters were hackable, but Bluetooth pacemakers cannot be hacked, or it can be hacked in future, but not possible till now because they are encrypted. So this is again similar way, the mobile from pacemaker to mobile app, and from mobile app to CareLink server, and we can access the server and find out the data. So again, there is evidence that there is 50% potential increase in survival rate, 35% potential reduction in ER visits, and length of hospital stay. So basically, AF detection is very important, and as Dr. Saxena was mentioning, silent AF is as bad as symptomatic AF. So silent AF episodes can be detected by these devices very beautifully, and we can do justice by putting these patients on pacemakers. So highest published AF detection accuracy is there with these Azure pacemaker till now. So longevity has also improved because of the improved circuitry and the low tooth blue energy system. The average longevity of these pacemakers is 13.7 years. So batteries have really come a long way. As I was discussing about Micra, even in fully dependent pacemaker patient, the Micra can last 12 years. So battery has come really a long way, but there is work going on for lifetime battery, which industry may or may not want to bring in, but yes, that's possible in future. Thank you so much once again.
Thank you, Dr. Jitendra. Thanks for elaborative. Doing well. So what is the medical legal implication for this?
Well, when we implant such, there is a contract which is signed by the patient. So it should not have any medical legal, but yes, it is a, moral responsibility of yours when you have implanted a Bluetooth devices. So when I started these devices, that was my biggest concern, which I put in front of industry people also. And they assured that they will track for some time till our team is built. Basically, actually, it should be monitored in a pacemaker clinic where there is a trained technologist who knows about the arrhythmia. Then there is a doctor on call which can follow up. It cannot be done by a single person. We can go crazy using these devices. So all the centers who have, I am trying to link it with my HF clinic. So because we have people there who understand about these things. So soon we are going to integrate that. But till now, frankly, these patients are taken care more by the industry people. They inform us personally and then we put the remedy on table.
Any other question from the audience? Can we move to the next session?
Yeah, thank you.
So next session is by Dr. Nishit Chandra. So he is the most sci-fi guy of cardiology, always having latest and updated information, not only from cardiology, but also for all the devices. Also, which are probably work for a few years at least.
So good morning, everybody. And first of all, I must thank
my close friend Jitender for letting me gate crash this EP meeting. So the disclaimer is that I am not an electrophysiologist, and what am I doing amongst all the electrophysiologists? Whatever electrophysiology I have learned is from my close friends who happen to be electrophysiologists, Dr. Anil Saxena, Aparna Jaswal, Jitender Makkar, Dr. Claire. So what I shall be basically taking you away from electrophysiology, but I would be rather telling you what you have to do gainfully with your mobile phone to enhance your electrophysiology career. So it is said that technology is a useful servant. Yes, but it's a dangerous master. So you should not let the technology overwhelm you. Rather, you should use it as your servant for meeting your own goals. So if we see the penetration of internet around the world, you can see India is not lagging behind. It's about 50 to 60% of the population is having internet access. And because of the sheer population, India is among the top 100, more than 100 million users are there for internet. The Indian population continues to increase, but the internet users, and so are the internet users. The number of internet users in India increased by 47 million, 8% between 2020 and 2021, riding on the wave of COVID. So, and the social media penetration is also, you can see, while the internet user was 8% increase, the social media penetration and increase was 21% in this COVID period last year. So this is the immense potential which is needing to be tapped, not just for forwarding WhatsApp jokes, but for enhancing your professional career. It could, right now, today I will focus upon the electrophysiology, but it could be any specialty in medicine. So you can see that behind China, we are number 2 in the number of internet users, just because of the sheer population. And this increased population, vast population, needs to be tapped. And unless you know the tricks and trade of social media use in your professional career, you will be missing this boat. So what are the social media platforms? The platforms, the most commonly used is YouTube, 85%, and Twitter and LinkedIn. So today I'll basically focus upon the Twitter one. So, and you can see the humongous growth, 31% growth in active social media user. This type of growth is never seen in any other unit. The average daily time spent in internet user varies, but in India it is from 6 hours, and for social media is about 2 hours per day. So, and this growth is driven basically not by desktop, nor by tablets, but by the device which you all have in your pocket, that is smartphones. And it started with initially in the 90s as a text message, then came messaging apps, and now is the time of social media. So it's high time that you should know the tricks and tips of social media use. There were about 1.1 billion mobile connections in India in January 2021, and this number is continue to grow. So, but we also have to know that how often doctors use social media for their professional growth. A study conducted in US, we don't have any Indian data. It shows about that about 53% of the doctors were there on a Facebook, and about 1/5 of the doctors, 21% were on Twitter, but this is gradually increasing. What I would like to convey that in the grand old time, the patient used to go to a doctor by just hearsay, word of mouth. No longer now. Now they go to the Google, they go to the sites, medical sites, Practo, Curify, Librate, and they read the reviews of the doctor. So you have to basically work upon your reviews. It's just like if you go to the Amazon and try to buy a product, you first read the reviews. Nowadays, most of the, as I showed you that the number of mobile connections, the number of social media users in India are gradually increasing with the tech-savvy people of India increasing. So nowadays, they don't depend upon word of mouth. They just go to the mobile phones, write the name of the doctor, and then read the reviews. So it's better that it's high time that you should work upon your positive reviews and act upon the negative reviews and take it seriously. So in next 10 minutes, I'll be telling you the power of social media, how it can change your life. And these are the platforms, the LinkedIn, Twitter, Facebook, Periscope, and Instagram. But today, this talk is basically limited to Twitter, which is a micro-blogging site which was founded 15 years ago, 2006. Initially, it was restricted to only 140 characters, and later the characters were doubled to 280. And you can see that this is my timeline, and I have these are cardiology-related tweets. So in Twitter, it basically, it's a breaking news of your topic or your topic of choice in your pocket as it is happening. And not only one-way traffic, you can interact with that news instantly from around the world. There is no hierarchy. You can discuss and talk to the latest and the most senior person in the field of your choice. So these are different, the way I use basically. I'll also tell you how you should use it. And there is in Twitter lingo, there is a one word, this is called hashtag. And this is basically is like a keyword that before, if you want to search a particular word, just put that hashtag before it, and then all the tweets which have this hashtag, you can search and instantly it will be in your pocket. So suppose if you want to learn about CRT, so hashtag CRT and search it, and instantly all cardiac resynchronized therapy tweets will be in your pocket, and you can refer to them, you can discuss with interact with the sender. So all the societies, be it Heart Rhythm Society, American College of Cardiology, all societies now they have their Twitter handles where they regularly tweet their latest news in their department. And around any conference, there are Twitter influencers, the conference people, organizers, they nominate Twitter influencer. We also have been nominated by the American College of Cardiology meetings, TCT, and European Society of Cardiology. They basically select the Twitter influencer in their geographic distribution. So he can then tweet live about what is happening in the conference. So you can then follow that conference sitting in your home just by following that link, that tweet of that conference. Similarly, the journals, all medical journals are now have their Twitter handle, Heart Rhythm Society. This is the HRS journal, and JAMA Circulation, Indian Heart Journal, NEJM, JAC, all have their Twitter handles. Just by monitoring these Twitter handle timelines, you can see their table of contents and then go to the respective article. Then there are certain communities which have mushroomed. There is electrophysiology. Suppose just like you have WhatsApp group of a certain, suppose Indian EP WhatsApp group, and you can post your case. Has limitation of 256 people only at one time, while Twitter has no such limitation of number of people who can join that group. It could be 1,000, it could be million, and you can interact instantly with those. You can send your dilemma, medical dilemma, interesting ECG, and instantly you will get the results from around the world, from the leaders of that. So I'll illustrate this point that in 2017, one electrophysiology EP physician, basically he tweeted about some device malfunction at 5 a.m., 5:50 a.m. in the morning. Within less than 1 hour, that tweet was read by an electrophysiology MD in University of Pennsylvania, and it was the cause was identified. Solution was offered by electrophysiology based in London, based on these tweets. and the Boston Scientific took corrected action within less than a month. An advisory was issued for that device. So this is the power of Twitter, that you can influence, you can report, you can collaborate with key opinion leaders as well as the industry instantly. So I'll just tell you a few important EP or social media links for you to follow. The Douglas Jipes, HRS online case reports. These are very, very easy, very, very important links. You just have to click these in these Twitter handle and all the HRS related case reports will be in your pocket. Venous arrhythmia, cardiac rhythm, and you have to follow a few important case, our key opinion leaders, our immediate past president of the EP Heart Rhythm Society India, Dr. Saxena. This is the Twitter handle, and my close friend, Dr. Aparna Jaswal. Fortunately, she follows me also. So you can just follow them and you will find all Twitter or EP related what is happening in India. Dr. Vanita Arora, Dr. Jitendra Makkad. And then you can, there are certain journals which you can follow in India. These are cardiac rhythm related news, and circulation, Jack, they have the EP content. You can follow them, and then this EP Lab Digest. This is a very important link which you can follow to keep the EP news live in your pocket. And this Heart Rhythm HRS journal. If you have to follow one journal, this is the journal which I'm mentioning to you. And this is the Indian Heart Rhythm Society. They also have a Twitter handle. So these are simple things which I'm giving you tips to start your Twitter career in electrophysiology. And what was the power of Twitter? Is it for me, basically, nobody knew me in international arena 3-4 years ago. I happened to be listening to this EuroPCR conference live in my lawn with my dog. And Patrick Sorois was basically discussing the Syntax 3 trials. And I just clicked this picture and sent it to EuroPCR. Look at this hashtag EuroPCR. Means all EuroPCR related tweets will be collated in this. And look what happened. In the EuroPCR closing ceremony, they projected this tweet, my tweet, in front of thousands of audience around the world. And instantly it got me a lot of name, and I got a lot of followers after that. And it basically launched my Twitter career in the cardiology field. So similarly, this was about Twitter. Facebook basically is for family related thing, but Facebook Live is one such concept where you can use it for your enhancing your career. Instagram is also basically for light-hearted discussions, but most of the key opinion leaders in cardiology are on Instagram. Dr. Aparna Jaswal is a very keen Instagram user. You can follow her. LinkedIn is basically for job-related queries and all, but also you can post your academic career-related issues on that. Periscope is a very important, very good tool by which you can transmit anything live around the world to your followers. You just have to download this app, and through that app on the mobile, you can transmit anything what is happening. Whatever is your mobile is seeing will be transmitted to any user around the world, to your follower, millions of followers if you have those much of numbers. So this is one such tool which you can use. It was used extensively for live conferences of cardiology demonstrating difficult interventional therapies. So this is how phone and social media has transformed our lives. And this is what? This is Kabul. And what was happening? Dr. Aparna Jaswal was sitting not in Kabul, but in her chamber and doing Facebook Live and teaching them electrophysiology concepts. Sitting across down, nobody can dare go to Kabul right now, but with the power of social media, yes, we can do and keep the bridges going. Another powerful to mention, just to quote you and just to tell you about the power of social media, is that Apple Heart study. In the history of medical education. Within 6 months of launching this study, more than 400,000 people joined within 6 months. This was the fastest recruited study anywhere in the world on Apple Watch study. And this was the power of social media, which let it happen. So recognizing the power of social media, Western countries had taken the lead. Mayo Clinic has social media residency program. They have social media fellows program and social media health care certificate. I wish Indian societies also start such thing, because this is and they offer social media scholarship for social media. But social media should not be misused. There are certain rules which you have to follow. You should be accurate in your reporting. You should never put a patient identifier in your tweets. If you have to, and you have to tweet some patient related, you have to ask permission, or some colleague, you have to ask permission from that person. Be always respectful and assume beneficence. So only if that tweet is of some benefit, then you should tweet that. And expect every message that whatever you are tweeting should be read aloud in court of law. So because it cannot be deleted. So you should not lie. Don't cheat because you cannot delete. Don't steal because you don't reveal. And this was basically a safety billboard which was put on German Autobahn to that you don't have to do tweeting or WhatsApping or Facebooking while you are driving. So you have to follow these rules. So ladies and gentlemen, with social media, you can enhance your career, you can collaborate, educate, advocate, and do research, and finally promote your practice. So it's up to you to launch your career through this mobile phone and decide whether technology is your master or your servant. Thank you very much. Thank you, Nishit. You are very right that Dipendra Bhatnagar sir, Dr. Sanjeev Sharma sir, Dr. Amit Gupta sir, Dr. Rajiv Sharma sir, Dr. Dinesh Gautam sir, Dr. Jitendra Makkar sir, organizing chairman of Jaipur Heart Rhythm Summit. Request to all of you, please come on a dais and chair the session. Thank you so much, sir. Now I would like to hand over scientific session to Honorable Chairperson.
Good afternoon, friends. All Dr. Jitendra Singh, I was telling him that he can be here to come further to learn in this part. Since we are very behind schedule, I straightly request him to come on this presentation, radio frequency application beyond previous case.
So basically, sir, the concept behind this talk was that
but actually EP study and radio frequency ablation is just not limited to PSVT. So there are a lot of arrhythmias which we can now ablate, and we are doing these kind of arrhythmias, which can actually give a lot of benefit to the patients. So apart from PSVT, we can treat atrial tachycardia, premature ventricular complex, VT, flutter, fibrillation, last but not the least, vasovagal syncope. So this is basically with the help of the new technology of 3D mapping, in which we can make the exact and help us in localizing the exact site of origin of the arrhythmia, where we can go and tackle with the arrhythmia and terminate it and burn it. So AVNRT, we all know about AVNRT. We are doing these cases. Just to add that we can even do AVNRT using 3D mapping technique, which is quite beneficial in a few cases. WBW syndrome, again, we all know about WBW syndrome. We have been studying this since our MBBS time. And just to emphasize that there are few patients who are taking, amidron and beta blockers, diltiazem for these kind of arrhythmias. And it's not difficult procedures. It's a very simple procedure. And most of the times patients are off medications after the procedure. So it becomes very important to refer the patients for radiofrequency ablation. So that, like this case, he was taking amidron since last 8 years. So he had pre-excitation in the ECG. So this was ECG showing P wave, slurred, upstroke, delta wave. So, and we did radiofrequency ablation. He was off medication after that. Similarly, post-receptal pathway with CS aneurysm. So now coming to atrial tachycardia.
So, Kush, if we can take some opinion about use of 3D for PSVT, for AVNRT and AVRT. Mike,
So, Kush, tell me in which clinical scenario you think, 1, 2, 3, which clinical scenario will use 3D for PSVT?
Sir, in all cases of anteroseptal pathway, if we talk about WBW syndrome, in anteroseptal pathway, I prefer doing 3D mapping.
Why? You want to mark the his, right?
Exactly, sir.
But again, means probably you're going to ablate with your signals, intracardiac signals.
I'm sorry, sir.
You are going to ablate with your intracardiac signals, not with the his marking.
Yeah, but so with 3D mapping, I know the exact site, that how far I am away from the his. So because my first priority is safety. So if we are away from the his, then probably we are doing justice to the patient. And that is why I use 3D mapping for anteroseptal pathway.
So to I'll give you, to add to that, means probably I will use an AV node reentrant or a AVRT in a field ablation 3D. Probably the first time, probably I'll go with 2D in all the cases.
maybe we can, yes.
Can I request Aparna and Anil to join on the dance?
We have 2 lectures coming on, so yeah, I think so. So basically,
Also,
okay. Basically, Dr. Noop, we have been doing PSVTs for years together without, and fluoro time is also not much with the practice, but it still saves some of the fluoro, and you are more sure about the position of his bundle. But yes, I don't think 3D mapping should be done, especially a patch should be opened or a catheter should be opened for PSVT.
So for AVNRT, I feel we should not open 3D mapping patch. But for right-sided pathways, suppose right free wall pathway, so it's always better to use a 3D mapping for those pathways, because we can. Yes, sir.
I think failed ablations, it should be something where you should consider it aggressively.
So coming to my case of atrial tachycardia, so he was a 19-year-old male patient, and the ECG was done suggestive of multiple runs of atrial tachycardia, and his echo was done, which was suggestive of severe LV dysfunctions. Possibly patient developed, tachycardia-induced cardiomyopathy, which is quite common. So this was the ECG of that patient. So we can see that these are normal P waves, and we can see burst of this atrial runs, and these burst of when these tachycardia in burst is suggestive of most likely atrial tachycardia. So we did 3D mapping, and for atrial tachycardia we always use 3D mapping, always. And so this was localized in the right superior pulmonary vein, posterior aspect. And important thing is that after termination of the tachycardia, when we did the follow-up of the patient, the ejection fraction improved to 55%. So this is the important thing, that whenever there is severe LV dysfunction and there is some tachycardia going on, so we should think that it can be because of tachycardia induced, but patient can be, tachycardia induced cardiomyopathy. So there are two possibilities: either because of LV dysfunction, patients having tachycardia, or because of tachycardia, patient developed LV dysfunction. So if we feel that it is because of the tachycardia, patient developed LV dysfunction, then probably by treating that tachycardia, his LV will improve. And we have, in all our experience, all of us experience maybe passive VT, atrial tachycardia, PVCs. Most of the times, ejection fraction improves after terminating the tachycardia. After getting rid of the tachycardia and follow-up, EF improves.
Yeah, I think in this chicken and egg story, you must focus on your echocardiogram very well.
Yeah.
If you have gross chamber dilatations, then you know it is the cardiomyopathy which has been responsible for tachycardias. And if it is not so, then you should more look at tachycardia causing the cardiomyopathy.
Sometimes it is difficult to find out, as she is saying, Murgi pehle hui ki anda. It is very difficult to find out, but even if there is heart failure and there is a tachycardia, atrial tachycardia, no question you have to ablate. Even if it is atrial fibrillation, there is evidence now clear-cut that the AF ablation improves the mortality and life quality of life in heart failure. So any tachycardia with heart failure should be ablated and should be aggressively treated. Now, whether it was tachycardiomyopathy or not, it will be a retrospective diagnosis.
Exactly.
Because the one best diagnosis is that the LV function is reversing after tachycardia ablation. Otherwise, it is very difficult to find out whether it is tachycardiomyopathy.
And this is the advantage of 3D map. So this is basically left atrium. These are 4 pulmonary veins. So we can exactly localize the site of the origin of the tachycardia, and we can go and terminate that. So coming to the next case, so she was a 50-year-old female patient and post-ASD surgical closure, and she was having symptomatic flutter with past ventricular rate, I think since years. Echo was done again, her EF was 40%. She was taking all rate controlling agent, and this was the ECG. So bit difficult to say, but yes, we can see some sort of flutter waves in lead 2. So she was having basically atrial flutter, and this is the ECG after getting rid of the flutter. So we can see now the P wave followed by the QRS, and there is no flutter waves present. So this is how we terminate the atrial flutter in 3D map. So this is basically right atrium, and this is tricuspid annulus, this is IVC, SVC, and we give burn in these areas to get rid of the atrial flutter. So just to emphasize that again, these arrhythmias can lead to LV dysfunction, and after termination, EF improves, and also patient gets rid of the medication. So most of the times, we don't need to give any sort of beta blockers or CCBs or amidron, most of the times. So this is an added advantage of doing radiofrequency ablation, not only symptoms, but also the medications. So any...
I think atrial flutter, the success of ablation is so high that we must work on it, and other medications and the stroke risk, which we must talk about, because if you let the atrial flutter be there, you have to treat it as if it were atrial fibrillation. Hence, I think when you see a typical atrial flutter, we know that it's very rewarding. We must consider radiofrequency ablation.
Yeah, that's the thing from my side. Structurally, you can't get flutter. Obviously, 3D mapping of flutter is very easy, because when you are doing the keyword like SMS ablation, you know all the points are correct. So you have got a beautiful dilation now. But if one is an issue, especially normal, it's still getting flutter with standard 3D mapping. This case, obviously, like your AAD, the EC doesn't look like a CK flutter, but inside,
Yeah, exactly so.
It is a scar because the air repair has returned, so you have created a growth also.
And many times you updated the flutter and then it's said like you see other establishing flutter. So no question, structural heart disease, post-op, all flutter or all age segment should be there under 3 plan. No question.
Yeah, the only question is, because of the cost, supposedly we have a bad LV with a dilated LA, and you have one episode of atrial flutter, which was successfully treated with amiodarone and all those. After that, there is no recurrence. Supposedly, it's not so common. Would you, it's still advise, because the question is how far you can decide that recurrence will not be there, especially when LA is dilated. Especially
exactly,
the
sir.
cost is the issue. So,
Yeah.
or even when you can successfully control it for say about 1 or 2 months, after that you decide when to go for this ablation. That is the question, because recurrence is again a question.
So very good question, sir. So basically, we're talking about atypical flutters arising from the left side. So any flutter which is arising from the left side, atypical flutters, they usually require pulmonary vein isolation. I mean, we have to treat the atrial fibrillation flutter subset kind of thing. And there are chances of recurrence. Definitely, whenever we go for AFib ablation, we have to explain the patient. We have to explain the patient that there will be a risk of, there can be a risk of recurrence. So we have to be prepared for that. In fact, in my training, it was like we will go for 3 times ablation. We will try 3 times ablation, and after that there is recurrence. Then we will label them as a case of permanent AF. So recurrence risk is always there, especially in these kind of arrhythmias, which has to be taken care of.
Your question was that if patient is stable on amiodarone, that after amiodarone he didn't have recurrence,
Okay.
then still you should go for ablation or not. So it is okay if patient is stable on amiodarone, but again, amiodarone is a very toxic drug and it cannot be taken for long time. That is for sure. Not for 5 years, 10 years, 20 years. Somewhere down the line there will be recurrence and you have to do that. Earlier you do lesser early control recurrence, later you do more recurrence. LA size, as he is saying, atrial flutter and atypical atrial flutter and atrial fibrillation, it matters, LA size matters a lot. But for typical counterclockwise or clockwise flutter, LA size doesn't matter. Still, the results of ablation for this atrial flutter are very good. So by ECG only, we can make out this is a typical flutter or atypical flutter. If it's typical flutter, we don't look at the LSI and we try to do it. But if it's atypical flutter, our also first tendency to give medication. This is actually very tough.
Yes, sir.
And recurrence rate is high, complication rate is high when you enter into the
Why not doctor amiodarone when you want to do long-term drug? I think the choice should remain with beta blockers, and then no structural heart disease, I think that's one place that class 1C must enter.
Yeah, we develop with this. The only thing you know is for flutter 1C. Sometimes the 1C does really flutter. You don't know whether you do 1C or flutter.
Is there any chance of developing pulmonary venous obstruction?
Venous
Pulmonary vein stenosis?
Yes, definitely, sir. That is a risk. That is one of the risks which again we have to explain to the patient.
Behave like mitral stenosis.
Exactly, sir. Behaves like mitral
It's a
stenosis.
very tough kind of complication, but again, with 3D mapping, sir, we do circumferential ablation. We are always out of the ostium, and we have created a larger area around the ostium of the vein, and we avoid entering inside. So without 3D, initially we did some cases at the sports, but also without 3D, and that was called ostial ablation. There the chances.
But still, we have to explain the risk to the patient, pulmonary vein stenosis. So this is again a case of atypical atrial flutter, and there we had to take care of the scar area also. Like sir mentioned, these cases has to be done in 3D mapping. Now coming to the atrial fibrillation, as we were discussing. So he was a 45 years old male patient complaining of recurrent palpitation, and he had paroxysmal AF, structurally normal heart on amiodarone, beta blockers, anticoagulant, but still he had persistent episodes of AF. So we did the radio frequency ablation, and after ablation, we were successful. And most importantly, again, so the best part is, so this is basically left atrium. So this is left atrium. These are the 4 pulmonary veins, and we do, as sir was mentioning, we are quite away from the os of the pulmonary veins in the LA. So the chances of development of PVI, we make sure that that we are away from the pulmonary vein, so that we don't want any complication during the procedure or after the procedure. So post-ablation, the best part is that if there is tachycardia-induced cardiomyopathy, EF will improve. And most of the times, you won't be requiring amidon for long, and patient will be asymptomatic. So this is the best aspect. So any call on anticoagulant, ma'am? In these kind of patients after ablation. So what's the role of anticoagulation?
Discontinue anticoagulation to understand that exists. We need to put the patient send them on anticoagulation and continue to do surveillance.
Yes.
And if a veteran person see that the patient is free of atrial fibrillation, depending on his CAD score, you will then take a call and then discontinue the anticoagulation.
Kush, a couple of points in AFib. If you're thinking about AF ablations, so there are two important things. One is young patient who has got a typical paroxysmal AF, and if you have got the initiation of AF with a PAC, though these are the subset of patient who does really well with the AF ablation, and most of the time these are structurally normal heart. If the patient has got a structural heart disease and dilated heart with LV dysfunction, then the AF ablation results are 50% success. That need to be counseled to the patient and family that probably will require 3, maybe 4 procedures.
So we only do for AF ablation in structurally normal heart. We don't do AF ablation when there's abnormal heart or dilated LA.
One or two persistent AF with long-standing AF, I can say, instead of chronic AF, then normal.
So coming
for anticoagulation post ablation is very important. So there should be a certain maybe 3 to 6 months is a good time to continue this and then AF surgery. So recurrent holters may be very cumbersome. Even the Apple Watch can be very easy to detect AF. And there are multiple kind of monitoring devices. Because we have to rule out something. And it also depends on Jhrs score. Jhrs score is very high. I would say
we have to give. Yes, sir. Definitely.
That's very important. If the Jhrs score is 0 and after 3 months, suppose you have got a few non-sustained AFib also after ablation, you still can get off with the anticoagulation. There's no need to give.
So coming to PVCs. So PVCs are very common arrhythmia which we see in our day-to-day practice. But seldom we realize that these are arrhythmias. These are basically arrhythmias which we can treat and which can be beneficial to the patient. So giving a case example, so he was a 29 years old male patient. He was complaining of palpitation, and his echo was done, which was suggestive of LV dysfunction, moderate LV dysfunction, EF was 40%. And we always do a Holter monitoring for PVC, look for the PVC burden. So his PVC burden was more than 20%. So whenever there are PVCs, get a Holter monitoring, look at the PVC burden. Low PVC burden, we don't need to do anything. High PVC burden with LV dysfunction, definitely he should undergo radio frequency ablation. So this was the ECG. So I think it's clear that a lot of PVCs are coming in a bigeminy pattern. So Holter monitoring was done. Again, the burden was more than 20%. So this was the PVC which was basically arising from, I think it was coming from RCC. Yeah. So this is the right coronary artery, and we were doing radio frequency ablation in the right coronary cusp. So this was very close to the His. We ablated in RCC, and post ablation his EF improved. So again, this is the advantage of this radio frequency ablation. So we can improve the ejection fraction in patients who have PVC induced cardiomyopathy. So any patients with PVC should be evaluated.
Yeah, so again, here comes the question of PVC coordinate.
Exactly, sir.
So in case, go back to the patient details. Yeah, so if ejection fraction is, for example, at this stage is 30%. So shall we do ablation first or put an ICG?
Obviously ablation, like, if it is a PVCs, there is no documented VT, you ablate the PVC, because yesterday also I was saying, and depend upon from where the PVC is coming, like, what he showed is the outflow tract PVC again coming from the superior part of the annulus of the aortic annulus. So outflow tract PVCs never produce LV dysfunction, never produce outflow tract PVCs. Outflow tract PVC does produce LV dysfunction. So obviously, if it is outflow tract PVCs, ablate first, see for the LV function, and then decide.
One more point is, clinical learning, I think it's very important that you actually need to consider, think about PVC ablation and refer to medications. When you see a holder and you find that if there is LV dysfunction, yes, the pressure will be low. But when you see a very simple rule of thumb, if you see more than 10% PVCs in a holder, or more than 10% PVCs in a holder, or more than 10 PVCs per hour, this number is number of 10, and just keep it in the background. If you really expect 14 to 15%, then it is considered. If there's LV dysfunction, the threshold should be lower. And this is a very simple rule to understand and keep in your memory. But yeah, I would like to consider, you should think of ablation by this number.
So important thing is to get in Holter monitoring whenever we see a ECG with frequent PVCs.
Yeah, so including message to colleagues that you see a lot of patient PVC whose echocardiography is normal and you consider they are benign PVC. You tell them you don't think anything was the right data of this. It's absolutely fine. But we should do a holder and see the PVC burden, within as Dr. Arman mentioned. So if burden is very high, we should consider the radiofrequency ablation. Particularly if LV dysfunction is already set in, then we should do PVC ablation in all cases. And sometimes, because of very symptomatic PVC, when they are not being controlled by beta blockers, I would prefer doing an ablation instead of underground. Because the ablation technology has become a part.
Definitely.
So we can refer them for ablation who are very symptomatic PVC. Sometimes the PVC can be very symptomatic, just as impending doom as somebody is going to die, like that. So in those cases can be done. And one very rare kind of indication I remember is I did in very early career. There was a patient who had activity and PVC. So I put a CRT in him straight away, and he was a non-responder. So whenever we used to interrogate the device, it says less than 50% of ventilator facing, because he was already always in the bigen. So in that case, it was very close to mid-control, and I was not afraid because CRT was
already in, yes.
So it was very interesting, and then after I thought I must have done it before CRT. The device.
So PVC should not be ignored. So coming to my next case, so it's a very interesting case. In fact, it's a very common case rather. So a fascicular VT, we all know this variable sensitive fascicular VT. So we see a RVB pattern in V1 narrow complex to dissociation. So he was a young male with a fascicular VT, and again we did the radio frequency ablation. So most of the times it arises on the left side of the septum, and we try to use 3D mapping. If patient is not affordable, then only we go for 2D mapping technique. And sometimes these patients, they develop tachycardia-induced cardiomyopathy. In fact, I've seen 2 or 3 patients with tachycardia-induced cardiomyopathy, and after ablation, they respond very good. So these kind of patients are very, very good responder. So like atrial flutter, fascicular VT should always be ablated. Typical atrial flutter, fascicular VT should always be ablated, and chances of recurrence rates are also very low.
The identification of fascicular VT is very important. Like this ECG in front of you, we used to read in the book that ECG is like an elephant. Once you see, never forget. See an elephant. So look at this very carefully. It looks like PSVT at a glance because the QRS is relatively narrow. But whenever you see a narrow QRS RVVT tachycardia with negative QRS in 2, 3, and areas, always think of a fascicular VT, and very typically it's found in young people, young patients, and interestingly, it terminates with adenosine as well as paratonine. So most of the time, the diagnosis is going on as the PSVT, but prognosis of this tachycardia is worse than PSVT and very well amenable to patient. So it is very interesting to identify fascicular VT. This is the most wrong diagnosis we get from the periphery written as PSVT.
So any call on 2D and 3D mapping, sir?
Kush, I'm a old timer, means, I don't believe in 3D for fascicular VTs. I ablate all fascicular VTs in 2D. The reason is because, you are ablating during tachycardia and you are looking for the Purkinje potential. So most of the time you are successful. The only thing for a fascicular VT, many times the echo is very, very important. You need to see a false tendon, and sometimes you have to go beyond beneath the false tendon. So probably ICE catheter intracardiac echo gives a very good idea about the false tendon and ablating the fascicular VTs. 3D, yes, if it is unsuccessful on 2D mapping, you are unsuccessful on 2D mapping, and then you want to tag those Purkinje potential on 3D and you want to ablate on 3D, it's a different thing. But I still believe, most of the fascicular VTs you can get away in 2D mapping.
I remember Dr. Saxena doing physical just go to the retrograde view and put the catheter on septum and go and bateं काम ज़्यादा.
But you see, off late we have started using 3D because it's not only for success of procedure, but to reduce the radiation time and the ability to go back to a previously tagged position and to create a more continuous line. Supposing you want to create a line, then linear ablation. So you can create a more contiguous line by 3D mapping as compared to 2D, because you have better visibility. Definitely.
Normally what we do, is we put a hexapolar or octapolar is one reason. And that is how we do a linear measurement.
No, it's absolutely, yeah, it's a personal choice, but, and results may be almost equal.
No doubt it can be done without it, but it is very handy.
Definitely.
It helps us in coming to that area. Suppose the catheter moves away. So that is the most important. Like, yeah.
Most common bump tachycardia is you take the catheter to the point and it doesn't never comes.
This is what right fever and facility. These are the two things where bump is very, very common.
So coming to VT, so post MI VT or maybe VT in case of DCMP, so these are very common actually, and most of the times these patients have already got ICD implanted, because definitely these patients require ICD. So it was a case of 71 years old male underwent angioplasty and ICD implantation. He had LV dysfunction and he was getting recurrent shock. So we interrogated the device and all the shocks were appropriate. That means that patient had basically recurrent VT despite on amiodarone and beta blockers and all the drugs which we can give. So what are the options which we have for these patients? Patients have been implanted ICD, and so ICD is a preventive therapy. It will not treat the VT. It will just, it will treat the VT, but it will not treat the cause of the VT. So cause can either be treated medically or with the help of radiofrequency ablation. So we planned a radiofrequency ablation under 3D mapping. So this is how basically we ablate the ablate ventricular tachycardia. So this is basically left ventricle, and we are ablating the tachycardia. These brown dots are the ablation points. So these brown dots are the ablation points on the septal aspect from where the VT arises basically. So the best part is that after doing radiofrequency ablation for these kind of arrhythmias, so what benefit we will get, that the shock which the patient is getting for VT will be decreased. Also probably in follow-up, the requirement of all the toxic medications might decrease. So these are the advantage of treating these ventricular tachycardia. So whether it is ICD or whether it is not ICD, so we can treat ventricular tachycardia with the help of radiofrequency ablation.
So this is one situation like where you will require 3D all the time. This cannot be done under 2D, because see, if there are two approaches, and it depends upon how stable the patient is and how bad is the LV function. So whether you want to do a substrate modification or you want to ablate the clinical VT, and in both cases, because see, you have to mark the scar, how extensive the scar is, you will require a 3D mapping. So obviously scar VTs are always done under 3D mapping. And again, it depends upon the operator, stability of the patient, how stable the patient is, what is the LV function, whether he wants to do substrate modification, or he wants to ablate the clinical VT.
When does he want to enter in VT ablation in a patient who has an ICD? There are significant trials now which tell us that you don't have to wait for a VT post ICD. So the take-home message, I think the threshold should be more when you see a meeting, you should want to refer the patient for an ablation because it can be, we know the shocks appropriate or inappropriate, increase the morbidity and mortality of our patients. So we must consider this ablation was very rewarding.
Yes, ma'am. And there are a lot of VTs which are idiopathic VTs. So I forgot to mention that. RVOT VTs. So these are all idiopathic VTs. So with structured normal heart. So we can treat those VT and the results are also very good. The recurrence rates are also very low for those kind of VT. So just another case of VT. So he was a case of, I think, ARVC, we ablated. And I think so last, any call on vasovagal syncope, the role of radiofrequency ablation in vasovagal syncope? Anyone, sir? Vasovagal syncope.
I have not done a single case, so means
No, I think
I'm not the right person to comment.
I think we are not doing cases in India mostly, but yeah, Americans and Chinese are doing a lot of cases of vasovagal syncope.
In South, means
There are few people that are doing, but in China especially and in America and in Chinese especially, they are doing a lot of cases of vasovagal syncope and the results are very, very rewarding. So I've seen cases, patients with Wenke bats, young patients, bradycardia, and after radiofrequency ablation for vasovagal syncope, immediately the ECG becomes normal, immediately on table. So the basic concept is, so I just brief and just, so there are certain receptors which are present in the heart, so which are responsible for the parasympathetic stimulation. And we all know that when there will be a parasympathetic stimulation, there will be bradycardia and hypertension, because of which vasovagal syncope will happen. So what we do with the help of these 3D mapping catheters and with the technique, we locate those receptors, which we already know where we get a tentative idea where the receptors are present in the heart. Mostly it is in the left atrium. So we get rid of those areas. So these are so we call it as, ganglion plexus. So these are the blue dots are the ablation points. And after doing these ablations, the vasovagal syncope drastically decreases and patient remains asymptomatic after that. So as for guidelines are concerned, I think it's class 2B. I think as of now, it's not recommended, but there are a lot of trials going on this concept. So maybe in future, we get a treatment for vasovagal syncope.
So I think from a very exciting session where Dr. Kush took us, my session is a little bit didactic, and I will be speaking on NOACs and stroke prevention in atrial fibrillation. NOACs, the non-vitamin K oral antagonists, and okay.
Slides.
Yeah. So what am I going to take you through in the next 15 minutes is trying to take home the message that non-vitamin K oral antagonists for SPAF certainly are superior to VKAs. A little bit about the pharmacokinetics, randomized trial data and meta-analysis, and what is the real-world evidence, and where are we on the clinical guidance on the use of these molecules in situations which we are faced in our day-to-day clinical practice. So I think most important, we have to understand that when we see a patient of atrial fibrillation, the first thing we try to identify is Is it a non-valvular atrial fibrillation, meaning the patient should not be having moderate to severe mitral stenosis and should not be having a prosthetic mechanical valve? Once we rule those two out, then we are dealing with a situation where the patient needs stroke prevention, which can be considered for these molecules after having calculated the Chad's-Vasc score. We have also understood that when we give aspirin, there is 22% relative risk reduction in stroke prevention when compared to placebo. However, if we were to give a VKA, it causes 38% relative risk reduction when compared to aspirin. And when we give non-vitamin K oral antagonists, the reduction is even more significant when compared with the vitamin K antagonists, which brings us to the point that we want to use a molecule which would protect our patients from stroke in atrial fibrillation, because the most devastating complication of atrial fibrillation is the ischemic stroke that we see. And if on those patients who are on warfarin or acetylene, we see intracerebral bleeds. We have also understood by now from randomized trials that antiplatelet monotherapy is not recommended. It is a class 3 recommendation for stroke prevention. And we all agree that we have all moved away from vitamin K antagonists, and both the patients and physicians today are eager to embrace non-vitamin K oral antagonists for the reasons I think I don't need to cite any longer. And we are all aware of the issues with vitamin K antagonists, which brings us to the non-vitamin K oral antagonist phase 3 trials. The first trial that was published and the first molecule to have the FDA approval for SPAF was dabigatran. The RELY trial was published in 2009, and subsequent to that, there has been a flurry of trials with the molecules. We subsequently had rivaroxaban, then we had apixaban, and of course the latest being edoxaban. In India, we have dabigatran, we have rivaroxaban, and we have apixaban. There are several advantages that non-vitamin K antagonists have over warfarin, which I just cited, that there were so many issues with warfarin. And if you look at the coagulation cascade, you see here that warfarin acts on several factors, while when we give these factors, the factor 10A inhibitors act on and inhibit factor 10A. Dabigatran is a direct thrombin inhibitor. There is a great advantage when this happens. It has been said that while these molecules are superior to warfarin in protecting our patients from ischemic stroke, they also reduce, the biggest benefit is they reduce intracerebral bleeds. One of the reasons being that when we give vitamin K antagonist, it acts on all the coagulation cascade in the brain. So thus, NOACs have several advantages over vitamin K antagonists, which we are well aware of. On this busy slide, I want to bring your attention to this point, that when you give rivaroxaban, you must remember that the molecule has to be offered, that the patient should be educated to be taken with meal. The second thing that you need to focus on this slide is renal clearance. Remember, atrial fibrillation is a problem of elderly. It is those patients who have frail kidneys, they have CKD. We must remember the renal excretion of these molecules. Dabigatran is renally excreted 85%. Now, that's a word of caution when you have patients with CKD, elderly, that you would want to be watchful of which molecule, while apixaban is excreted, renal excretion is only 27%. I will take you just through one of the studies of apixaban, which is Aristotle. The Aristotle study, which was published in 2007, was done with this molecule apixaban. The mean CHADS was 2.1. Now, what is this CHADS and CHADS-VASc? I think each of us should remember that if we want to treat our patients of atrial fibrillation, when we have identified them as non-valvular, we must calculate this clinical score, which now we use is Jhrs. It has been around for over a decade now. And if we calculate the Jhrs score to be 2 or more in men, 3 or more in women, the patient should essentially be on an oral anticoagulation, and NOACs are to be preferred over vitamin K antagonist. So this is just an overview, entire overview. When apixaban was studied over warfarin, it showed it was to identify non-inferiority. However, it was seen that it turned out to be superior to warfarin with a 21% relative risk reduction for stroke and systemic embolism, and the safety endpoint. Apixaban is one of the safest molecules to treat for bleeds. It had 31% relative risk reduction, and the key secondary outcomes which I want to bring to your focus again is this. I just mentioned the problem of warfarin, apart from others, has remained the intracerebral bleeds. There was significant reduction of intracerebral hemorrhages when apixaban was given compared to warfarin. This is just to highlight. So Dr. Drazen was the editor of NGM, and it was thought that Aristotle clinical trial was published in the 12 top trials which were practice changing, that Aristotle told us that apixaban is going to be a game changer in stroke prevention in atrial fibrillation. So if we were to compile all of these trials together and we were to see NOACs versus warfarin, stroke or systemic embolism, most significant reduction came from dabigatran 150 BD and apixaban. However, when you looked at intracerebral bleed, maximum reduction was with apixaban because it did not have the same with dabigatran 150 BD. NOACs versus warfarin, all-cause death, again there was 10% reduction with apixaban. And major bleeding, I already told you, apixaban stood to be the winner, also followed by dabigatran 110 BD. Thus, if you would look at the summary of the major efficacy and safety outcomes, all of them had certain pointers and you could decide which molecule in a given patient. But apixaban reduced stroke and systemic embolism, reduced intracerebral bleeding, had benefit in mortality, and was significantly better in major bleeds. Do we have a data from Asia and India? Yes. We had small representation, but we do have in the Aristotle trial, and it was seen that from the Asia Pacific, there was even more significant reduction in bleeding. Was this further substantiated in the real world? Yes. The largest study that has been done is the Aristophanes study, which had enrollment of about more than 4 lakh patients. And this was not a head-to-head trial. We have none of the trials where these molecules have been compared head-to-head, but have been compared by what we call propensity score matching, where an attempt is made to reduce the possible bias. What did this tell us? The real world evidence that compared with warfarin, apixaban was associated with 36% relative risk reduction in stroke and systemic embolism and 40% relative risk reduction in safety outcome of major bleeding. When we tried to compare the molecules amongst each other, again, apixaban was associated with significant reduction compared with dabigatran as well as rivaroxaban. How do I manage my patients when I'm faced with elderly patients? Because I think this is a problem all of us face in our clinical practice. When you see an elderly patient, you understand his Jhrs score is high, but he will also turn out to be a higher risk of bleed. Having a high Has-Bled score under no circumstance tells us that we should not give an oral anticoagulant, but all it tells us is that we should work even more aggressively on the modifiable risk factors, meaning thereby if the patient has a hypertension or is on other drugs or is consuming alcohol, that's the modifiable factors which you can bring a change, but you have to treat them and engage with the patient and do a shared decision making and treat them with oral anticoagulants. So if we were to see in the elderly patients and the elderly patient beyond 75 years of age, stroke and systemic embolism, apixaban versus warfarin, apixaban did good enough when compared to those who were between 65 and 75. But look here, when you were to see the benefits of apixaban in the elderly with reduction of major bleeding, it was even more when compared to those who were younger than 65, which tells us that we must consider stroke prevention in atrial fibrillation by choosing the right molecule in the elderly subset. If you look at all of these molecules together, well, it is compelling, the data is compelling, and we have to see that apixaban fared better in stroke and systemic embolism, major bleeding, and a reduction in intracerebral bleed in patients who were elderly. If you look at the mustard bar, this is again telling us that warfarin fared the best from the meta-analysis. So this is very interesting. It is called the FORTA classification. It was published in 2019. It's called Fit for the Aged. And there are certain lists of drugs which fit in here. And A is apixaban, which fits in here, that is indispensable, while others can be used, but the drug which fares the best for the elderly is apixaban. What do you do in patients who are renal compromised? We understand that CKD patients have a problem of increased thrombosis, as well as they have a problem in the coagulation cascade, and they are prone to more hemorrhages. First thing, whenever we give patients oral anticoagulants, we always calculate the creatinine clearance. Those patients with compromised creatinine clearance, you should calculate often. You should calculate creatinine clearance divided by 10. So we understand, I told you at the very outset, that dabigatran is 85% excreted by kidneys, rivaroxaban is 33%, while apixaban is 27% excretion via kidneys. And we've already talked about in the Aristotle trial, it reduced what we were looking for, stroke and systemic embolism, as well as major bleeding. So where are we with apixaban label? Well, in renal failure, we must remember those patients whose creatinine clearance is more than 50, you can give dabigatran, rivaroxaban, edoxaban, and apixaban without worrying. But the whole issue comes when the the GFR is less than 50. Between 50 to 30, we should be careful. Less than 30, we have to be extremely careful because our patients have a risk of bleed. Whenever we give apixaban, we look at three things when we write the dose of apixaban. Age, if the age is more than 80, weight is less than 60, or creatinine is more than 1.5. If you have 2 out of 3, you have to give the lesser dose of apixaban, being 2.5 milligram twice daily. Well, how do we deal with patients who have high risk of GI bleed? Now, this is something which is extremely important because we understand that when we give NOACs, while we are trying to protect our patients from an ischemic stroke, they also get on board the risk of bleed. NOACs have helped us reduce the risk of intracerebral hemorrhages. Where are we with GI bleed? Well, we worry with GI bleed. We're dealing with frail patients, and the reason is that there is incomplete absorption as a result. There is a topical anticoagulant effect. There is a direct caustic effect because some of these molecules like dabigatran are packed with tartaric acid, and there is inhibition of mucosal healing. These features enhance the risk of patient having GI bleed. When we were seeing the rates of major GI bleed from the pivotal NOAC trials, which I just spoke to you, be it RELA, be it Rocket AF or Aristotle, it was seen that the least GI bleeding was with apixaban. There have been several studies published repeatedly that the conclusion was that apixaban and edoxaban had the most favorable major GI bleeding safety when compared to dabigatran or rivaroxaban. What do the guidelines tell us? Well, the ESC 2016 told us patients at a high risk of GI bleeding, a VKA or another NOAC preparation, meaning apixaban or edoxaban, should be preferred over dabigatran or rivaroxaban. Those patients with a history of bleed, well, the beneficial effects of apixaban over warfarin for stroke, hemorrhagic stroke, death, or major bleed remained consistent regardless of a history of bleed, both from Aristotle as well as Aristophanes. We have realized that what are we all trying to do? We are trying to reduce the patient's risk of ischemic stroke. At the same time, we have to identify a molecule which is most superior to a given patient. It is not to say that every patient earns a specific molecule. There will be specific situations where you would want to give a dabigatran or a rivaroxaban or an apixaban. But the data is compelling for us to understand that if we were to choose a molecule with reduction in stroke and systemic embolism, as well as a reduction in intracerebral bleed and GI bleed, Apixaban does have significant data, but whenever we prescribe apixaban, we should, or any NOAC, we should choose the right dose. When you are treating patients with NOACs, you must calculate the creatinine clearance after having calculated the CHA2DS2VASc score. If the patient's creatinine clearance is more than 50, you have the luxury of choosing any of these molecules. When the patient's creatinine clearance is between 30 to 50, you have to be cautious. If the patient's creatinine clearance is less than 30, you should be extremely careful when you prescribe NOACs. If you choose to be using apixaban, you must calculate the patient's age, if it is whether it is more than 80, patient's weight, if it is less than 60, patient's creatinine, if it is more than 1.5. If 2 out of 3, only then should you want to use the reduced dose being 2.5 milligram BD. Otherwise, you should want to use 5 milligram BD. I think I would like to conclude here. Thank you so much.
Thank you, Aparna. Very
atrial fibrillation terminated tamaradron. After that, no recurrence. CHA2DS2VASc score is more than 2. How long to give and when to stop? How?
Yeah, I think if I may say that we're all looking for an exact answer to this, but what is most pertinent here is a CHA2DS2VASc score. If you have documented an atrial fibrillation lasting for a few hours on a Holter, I think, and if you've seen the CHA2DS2VASc score is 2 or more, you've not told me the exact, but 2 in itself tells us that the patient's annualized stroke risk is roughly. I think what I would want to do is inform the patient, put the patient on an oral anticoagulant, and as we have discussed previously, we would want to do AF surveillance and subject the patient to repeated Holters, extended loop recorders to identify the patient's AF burden, because we have learned that patients with paroxysmal atrial fibrillation with silent episodes of AF are at risk, as much risk of an ischemic stroke as that of a persistent or a permanent atrial fibrillation. So if the problem would have been if this patient's CHA2DS2VASc score was lower. So when CHA2DS2VASc score is 2 or more, I would be wanting to treat the patient with an oral anticoagulant.
One episode after cutoff, we usually take it more than 75. Dabigatran 110, 110 BD versus apixaban. Would you consider it different, superior, or is it same with normal creatinine?
Yeah, I think cost is a very major factor, and what I would really want is that the patient should be very well anticoagulated and should take the molecule. So I think you have a good point here that if the patient's creatinine clearance is normal, you may choose dabigatran 150 BD and continue 150 BD and not other molecules which are still under patent.
And age limit for dabigatran 110 BD is still 80 or what?
Yes, it is 80.
Again, let us.
Yeah.
Thank you, Patna. Thank you so much. Now we come to the last presentation, Dr. Anil Saxena. EP intervention atrial fibrillation, when and how? 3D mapping, cryo, and left atrial appendage closure. Anil, in the meanwhile, he is setting the system. I read somewhere, Nawaz Sharif underwent maze operation in London. What is the status at present? And he does not seem to have improved. That's what I read also.
Yes, sir. So actually, maze operation was when it started, Dr. James Cox started it, and he had the best results actually, 80-85%, 10-year success. And the catheter ablation actually will be that concept, what he initiated, that PV isolation and multiple lines across the atria. But these days, no surgeon is doing it. I mean, as a standalone surgery is hardly ever done. But in our hospital and many hospitals, it has been done as a add-on surgery in patients who have mitral valve surgery or some aortic valve replacement undergoing. And they also have atrial fibrillation. So it has been done with variable success. So as such, it's not something that we very actively promote or are very happy with. But very important point. So friends, this is the last talk of the day, and I will be as brief as possible. So atrial fibrillation is a very long topic, and all of us see patients of atrial fibrillation in our practice. It's a commonest arrhythmia. And when I was doing my MD, it used to be just an appendix to the diagnosis. We did not even know much about the consequences of AF and how to manage it. It was just rate control was the only thing that was necessary. But then we came to realize about the stroke connection, and for last 20 years, it has been very active. We know that there's overwhelming evidence, and as Dr. Aparna has beautifully discussed how to anticoagulate these patients. And I will talk about the other things. So most of the guidelines, they focus on first of all, when a patient comes with acute episode, so we have to control the rate to acceptable levels and try to manage the hemodynamics if patient is hemodynamically compromised. After that, we come to lifestyle modification and upstream treatment. And then we come to rate and rhythm control. And then, of course, in between, we have anticoagulation, which is the fundamental thing nowadays. Whenever somebody comes with AF, we have to see whether patient needs anticoagulation or not. In fact, 70-80% of them need it. So we have to find patients who don't need anticoagulation. And then we come to this rate and rhythm control therapy, which I will be briefly discussing. So rate control, of course, this was not part of my talk. I had to focus mainly on the ablation and occlusion, but I think this is a very important part for understanding of atrial fibrillation, that all of us should understand what is a good rate control. And it has been described as lenient rate control when we keep the resting heart rate below 110, and strict rate control when we want it below 80. So for most patients, lenient rate control is quite okay. They do fairly well, not much symptomatic. So our initial target should be trying to bring down the heart rate to less than 110 beats per minute. And if the patient has these three conditions which I mentioned on the left, that is, patient continues to be symptomatic, or has a fall in ejection fraction or low ejection fraction to start with, or patient is on CRT, then we have to bring it down to as low as possible because otherwise the CRT will not be delivered. As Dr. Anup was saying, like in ectopics, same way in atrial fibrillation, CRT will not be delivered if the ventricular rate is high. So that is one important concept. And to control the rate, we have, in the acute stage, we have diltiazem intravenous or beta blockers intravenous. We have intravenous digoxin. And of course, sometimes amiodarone when we cannot use, in acute heart failure, we cannot use IV beta blockers or diltiazem. Digoxin and amiodarone can be a very good combination in that setting. And for long term, we largely depend on beta blockers and calcium channel blockers. We don't like using digoxin for long-term rate control because it has been very inconsistent reports, but it has been found to be adverse as far as the long-term prognosis is concerned. And amiodarone as a rate control agent, we never prefer. So beta blockers and calcium blockers are the main things. Sometimes we have to do AV node ablation and pacing also. And this is the study that I was talking about, that digoxin is associated with increased all-cause mortality in patients with atrial fibrillation, regardless of concomitant heart failure. So this is something that we don't, that's why we don't like to give another meta-analysis, which again points towards a negative effect of the digoxin. So sometimes we have to ablate the AV node or modify it to control the rate. And then we can, of course, but the patient then becomes dependent on pacemaker or CRT, whichever. So when we have to choose between rate and rhythm control is preferred when the patient initially comes with atrial fibrillation, because we know that sinus rhythm is definitely better than atrial fibrillation. So we try to maintain normal rhythm as far as possible. In patients who are very symptomatic, it is definitely necessary. In younger patients, definitely it's preferable to have sinus rhythm. They have a long way to go. Or when atrial systole is important, like patients with hypertensive, hypertrophy or otherwise diastolic dysfunction, because these patients tolerate atrial fibrillation very poorly. Or when the AF is secondary to a cause, suppose somebody comes initially with AF and we find thyrotoxicosis, we must convert it to sinus rhythm and treat thyrotoxicosis. So any secondary cause should be treated, and then patient should be tried to be kept in the sinus rhythm. Rate control is okay if the patient is older and is asymptomatic and has contraindications to antiarrhythmic therapy and is unsuitable for cardioversion, doesn't want catheter ablation because very less symptoms. So these patients can be very well maintained on rate control without much problem. Now we come to the rhythm control part, which is basically my talk when the EPs are called in to help. And one of the things is in our hospital, at least EPs are called for cardioversion also, but not in every hospital. But whenever we do cardioversion, we must make sure that if the AF is of uncertain duration or has been lasting more than 48 hours, we must exclude presence of a thrombus in the left atrium or left atrial appendage. And that is usually done by transesophageal echo. However, patients who are on long-term anticoagulation, more than 1 month, they can be cardioverted without much problem, without TE also. And the reason is that sometimes there may be a thrombus in the left atrial appendage, which can dislodge during cardioversion. And one important concept I want to introduce here is that sometimes I find that somebody says that we cannot cardiovert because we don't know about the TE, but we have started amiodarone. Now that is a wrong approach, because any rhythm control strategy, whether pharmacological or electrical, is same. So even if we want to start IV amiodarone, we must make sure that the patient doesn't have a thrombus in the LA appendage, because cardioversion is cardioversion, whether pharmacological or electrical. So for long-term antiarrhythmic, fortunately we now have more drugs available like flecainide and propafenone, which are not available earlier, which can be used in patients who don't have a structural heart disease. But patients who have structural heart disease, we are limited to amiodarone and sometimes sotalol in patients who have good ejection fraction. But patients who have structural heart disease should not be given flecainide and propafenone, etc. That is of fundamental importance. So now coming back to my topic, that is atrial fibrillation for atrial fibrillation, when it should be given. What is atrial fibrillation ablation? Basically, there are several interrelated things that are done in catheter ablation. Most common, the central procedure is that we like to isolate the pulmonary veins, because it is now understood that it mainly arises in the pulmonary veins. So that is the central procedure of any AF ablation, that we isolate the pulmonary veins by, there are several techniques. One is segmental ostial ablation, one is circumferential enteral PV isolation, one is wide area LA ablation. And then we have in patients who are persistent or permanent or persistent atrial fibrillation, who have structural heart disease also, they have a lot of fractionated electrograms from the scarred areas in the left atrium, and we map them and target them. So that improves the overall long-term success of the procedure. So cafe ablation or complex fractionated electrogram ablation is another technique that is used in patients. But central procedure is PV isolation. And this is another 3D mapping picture where you can see this is the initial map, and after isolation we can see that the pulmonary vein area and the antrum are disconnected from the main LA. And that is something which one must check that the PVs are isolated or not. So what is cryoballoon ablation or for atrial fibrillation? Now this is basically another technique to isolate the pulmonary veins. Here a cryoballoon is used, which is like an onion-shaped balloon, which is passed over the guide wire into the pulmonary vein, the target pulmonary vein, and under fluoroscopic guidance or ice guidance, and then it can be frozen. The whole area around the pulmonary vein is frozen. So as it goes to -30 or -40, -60, you find that the electrograms they get, they abolished and pulmonary veins are disconnected. And that's how it looks on the X-ray, and that is the map before and after. We can see isolation of pulmonary antrum. And this is on the canine histological picture. We can see that the whole area gets ablated around the pulmonary veins. So this is a very quick and effective method of, it is not yet available, but it's about to be introduced. Medtronic, they have already brought it to India. It's not yet been installed in any hospital. So it just came to India last month, but it's something that we look forward to doing in next few months. It has been seen that it is almost as effective. In fact, there is a recent study which suggests that it has a lower significant recurrence rate as compared to the conventional. Now, as far as the indication for atrial fibrillation ablation is concerned, this is, I think, the most simplified picture I have ever found. This is from the 2017 Hrs, EHRA. So it's a very kind of robust guideline from Heart Rhythm Society of USA, European guidelines, and then Asia Pacific Heart Rhythm Society. A lot of societies have combined. And this is, so we can divide the atrial fibrillation into paroxysmal, persistent, and long-standing persistent. Long-standing is more than 1 year. So in paroxysmal atrial fibrillation, initially we try drugs, but in the drug therapy phase, then catheter ablation is class 1 indication. So that's class 1 indication in paroxysmal atrial fibrillation. In persistent, after again failure of drugs, it is class 2A indication. And in long-standing persistent, after failure of drugs, it is class 2B indication. Now, as a direct approach, supposing somebody comes with paroxysmal AFib, can we do atrial fibrillation ablation without trying any drug? Because drugs can be toxic, they have their own side effects. So that's a class 2A approach right now in paroxysmal AFib, but it's, and also in persistent AFib, but it's 2B indication in long-standing persistent. So that is the current status of trying to use atrial fibrillation as a first-line therapy. It's class 2A for paroxysmal and persistent, and class 2B for long-standing persistent. The success rate of AFib ablation is around 60 to 85, depending on the center to center and experience, and also the type of atrial fibrillation, the underlying disease process. There are so many factors which govern the success rate. It's very low in patients who have hypertrophic cardiomyopathy, for example, maybe around 50% or even less. And also, success rate is lower in patients who have very long-standing atrial fibrillation. Many patients may require a repeat procedure, 25 to 40% patients, and often patients require a combination of atrial fibrillation ablation and drug therapy to be managed. The risks for recurrence are higher in patients who have one of these problems like hypertension, high recurrence, patients who have diabetic, uncontrolled diabetes, obese patients, patients who have obstructive sleep apnea, patients who are dependent on alcohol, or continue to smoke, and patients who have dyslipidemia. So all these are risk factors which indicate that patient has a higher chances of recurrence. This I've already mentioned that sometimes we have to, very rare, I may have done maybe 2 or 3 in my long career, but this is something which is as a last resort, we have to sometimes do AV node modification or ablation, and then of course patient becomes dependent. The last thing I want to mention is about the left atrial appendage occlusion. Now, as Dr. Aparna pointed out, some patients may not be suitable candidates for anticoagulants. They have contraindication, or they have already had bleeding. They are not ready to take anticoagulation at any rate. So in those patients, LA appendage can be occluded because it has been found that it is the site of thrombus in about 90% of patients with atrial fibrillation who have thrombus and have stroke. Rest of them may have in cavity. So it can largely control the problem of stroke if it is effective. And there are many devices available. I will not go into the details of the device. Our Watchman is a very commonly used device, and it's available. Currently, it's a class 2B indication. That is in patients who have contraindication to anticoagulation or who are not willing to accept anticoagulation in any way. It's very expensive upfront, but then long term, it's very effective once it is successful. Peri-procedural complications are there. Device can dislodge, can migrate, and there may be peri-device leak, which can again make the patient dependent on anticoagulation. And of course, so currently the indication is that it should be considered in patients who are intolerant or have contraindication to anticoagulation. One last slide that is on, again, EPs are called to sometimes implant this implantable loop recorder in atrial fibrillation, especially in patients who have cryptogenic stroke, because we know that asymptomatic stroke can be a cause of stroke without any known cause. So if patient comes with a stroke and all the other things are normal, there is no other reason to suspect any cause of stroke, we often have to implant an ILR to detect asymptomatic atrial fibrillation. So that is also a class 2A indication nowadays, that if somebody comes with a stroke of unknown etiology, we should try to implant a loop recorder for this. So which can, it's a very small device implanted in front of the chest, and it can work up to 3 years. It can help in the diagnosis of atrial fibrillation and then patient. So patients after cryptogenic stroke are put on anticoagulation and are given ILR, and if they have no AF detected for 1 or 2 years, then it can be discontinued. So I think I will stop here, sir. Thank you so much for, and thank you everybody for this. Thank you.
Thank you, Doctor. Excellent presentation. You discussed everything in detail.
The felicitation ceremony and valedictory program, I would like to invite on a stage Dr. Prem Ratan Degawat sir. Please give a big applause. एक बार जोरदार तालियां हो जाए डॉक्टर प्रेम रतन देगावत सर के लिए. Thank you very much, sir, for your valuable time to make GHRS 2021 a grand successful. Kindly present memento to Dr. Prem Ratan Degawat sir. Heartiest congratulations, sir. Dr. Sanjeev Sedana sir. Once again, a big round of applause for Dr. Sanjeev Sedana sir. Dr. Nitin Kansal sir. Dr. Aparna Jaswal madam. Once again, a big round of applause for Dr. Aparna Jaswal ji. Thank you very much for your GHRS 2021 grand successful. Dr. Anil Saxena sir. May I request Dr. R.K. Madhup sir, please present him memento. And now it's time to celebrate as well as felicitate the two dynamic doctors and personalities behind this GHRS 2021
the person behind this whole conference. So please put your hands together for none other than Organizing Secretary of Jhrs 2021, none other than Dr. Krish Kumar Bhagat sir on stage. जोरदार तालियों के साथ हम सभी उनको थैंक्स करना चाहेंगे. So please give a big applause, Dr. Krish Kumar Bhagat. And now I'm going to invite. So please put your hands together, and if it is possible, please give him a standing ovation. Organizing Chairman of Jhrs 2021, Dr. Jitendra Makkal sir. I would like to invite all felicitators जिन्होंने भी अभी awards receive किए हैं for the group photograph. Request to all of you, please come on a dais. Request to all awardees, please come on a dais for the group photograph. Request to Dr. Sanjeev Sharma sir, please join us on a stage. Dr. Harpreet sir, request to you, please come on a dais and join us.
This initiative after COVID. Interestingly, before COVID wave started in 2020, February, late February and March onward, just before that we held this national conference of Indian Society of Electrocardiology at Udaipur. And many of us were there, and this is the first after COVID. So we were the one to finish at COVID and start after COVID. That is our pleasure. And this is a convention to say thanks to those who contributed. So Dr. Kush is my colleague, and he doesn't need a thank, of course, because it was his conference. But I must congratulate him for all the hard work put in behind this conference. And he is the future of EP in this part of country, and is very, very promising guy. And our team has been strengthened because I was been very busy with the other works and management, and then intervention also I started lately. So he has been very instrumental in bringing these new technologies ever since he visited China. This physiological pacing and 3D mapping, because we need a lot of time, so it has to be a team. And fortunately, we are emerging as a very good team in this part of country for EP. So God bless you, keep working hard, sky is the limit for you. And of course, for any, conference to get successful, you need a good faculty. And just now Aparna was telling me that this is a very good sense of security that you have some common friends and you just give them a call, मैं ये conference कर रहा हूँ, आपको आना है, and they say no. So this kind of security I always carry ever since I left Escorts Delhi, but we are in touch because of these conferences, and definitely we had spent a very good time there. So I thank especially Dr. Clay, Dr. Saxena, Dr. Aparna to make this, and with time, as their expertise is growing up and they are getting more experience, they are getting a very good orator also. And I, Dr. Anup Gupta, and we missed Dr. Vanita this time, but I think we should give a big round of applause for this highly expert and very polished and knowledgeable faculty which we had. And of course, our local guys, Dr. Sidana and Prem did a wonderful job. And our chair faculty, moderator, panelist, especially Dr. Madhok, who spent so much time with us, and he always has a hand of blessing. That is also a sense of security. कि सर को तो हम बोल सकते हैं सर आपको आना है, and he always graces us with his presence. And my colleague Sanjeev Sharma and Atul Kasliwal being part of this, and many other cardiologists, Dr. Dipenda Bhatnagar, Dr. Sanjeev Roy, Dr. Sunil Garsa came last night, Pushpinder, many other colleagues, I may miss some name, and some cardiologists out of Jaipur, Dr. Vivek, Dr. Rahul Gupta, and came, and my old buddy, Dr. Harpreet, he is again, we keep on finding such opportunities to meet each other, and he is a wonderful cardiologist working in Chandigarh. So he always blesses the occasion. Of course, delegates, if you have no audience, then faculty doesn't have to do anything. So I really thank from core of my heart to all those who attended since last evening, and some of my senior fellows, I can see them in the hall only since last afternoon. My senior colleagues, Dr. Prem Arora and Anil Khurana was from Jaipur. They always bless our conference. Prem Arora sir were there in Udaipur too, and they always attend very seriously. And from Alwar, Dr. Parvinder Singh came all the way from Alwar, and some other colleagues. I really want to thank them. And Dr. Suri sir from Kota, I can't take all the names, but I really thank you for sparing your time, particularly in this tough time post-COVID. And of course, then comes the big, team which we had to support this conference. Particularly, our marketing is ESCC team. Nitesh, big round of applause for you and your team. Other corporate hospitals are jealous of our marketing team, actually. That's the fact, and big round of applause everyone from your team. Wonderful work done. Then of course we have our big, I always get a very good support from industry, particularly this time Biotronic, Abbott, Medtronic and Boston Scientific, all four participated. Conventionally it was done by one of them, but now I'm fortunate to get all four of these big corporate guys to be involved in this conference, and they have donated generously and also worked hard to get people. And our all-time partners, big guys like Torrance, Sun Pharma, Lupin, and this time Cipla, Pfizer, USV. I thank you all from core of my heart. You guys have really worked hard, and I hardly can meet them, but they find me close to their heart, and I find them close to my heart. So big round of applause for all of you guys standing in the back. And I sincerely apologize for the little time I can give you when you are waiting outside my chamber, but मुझे पता है आपको किसी को बुरा नहीं लगता, because you know me very well and I also know you guys very well. So, you can see all this arrangement, flawless audio visual, flawless, faculty facilitation and transport and everything. This is done by our all-time champion now, Navneet and Vision Plus. And all these guys who have been sitting here behind this curtain for, last 24 hours, they have done a wonderful job. एक बार भी कहीं इतना जो है ना रत्ती भर भी कोई disturbance नहीं आया इस बार audio visual में. It was really flawless. Congratulations to all of you. And merit staff also, I would like to thank you for this. Thank you so much. If I missed anybody's name, I'm really sorry about that. But thank you so much, all of you. You all made it a successful conference. Thank you.